Well, I'm going to be normative for once. In the observatory, we're never normative. We're only about evidence. But this case, let me be slightly normative. We believe, those who've been researching, working in this field, that it's not a crisis of model. The model of Almaty 45 years ago, which has been renewed, of course, the Standard Declaration and all the measure reforms and best practice we heard, is as useful, as evidence-based as ever. All the evidence we have, and we collect a lot of evidence, you'll hear a fair amount of that today, is telling us that there's impact on health status, on outcomes, is core to universal health coverage, is at the very core of ensuring access to the health and the health system. And guess what? In a moment, as always, of economic crisis, it's value for money. As we compete for resources in the post-COVID era, we need, and we continue needed to prove that actually PHC is value for money. So the focus of today is we have the evidence, we have a strong model, where is the crisis and what we need to do about it. And of course, there's a huge difference in context, in countries, in different approaches. I'm aware of that. But in general, we'll be identifying today some of the areas where we need to strengthen, we need to reform, we need to transform. First of all, by the way, is making a better case for financial resources, as I said already, in primary health care, reallocating resources there. We'll be talking about a skill mix that goes beyond the family practitioner to all the range of allied health professionals in primary health care. We're going to be talking about integrating healthcare. So we're going to be talking about these key strategies to transform and implement this model. And to do that, we'll start, second part of the title, from Spain to Europe. Spain in many ways is a paradigm of that. Actually, I used to be a family doctor many years ago, and I've seen the transformation of this system. Spain in primary healthcare, and I don't want to be nice with the minister or with our Spanish colleagues, because it's based on evidence, as you'll hear from my colleague in the case study, has a very strong primary health care model, which was transformed into a public health element as well with the reform of many years ago, but also has a crisis. So we want to hear in which way the PHC model in Spain has been working, why is it facing also a crisis, what are the ways forward. And then after that, we'll go to Europe. I will be presenting this measure study that we've done together with WHO Euro and WHO headquarters under the leadership of the global program, in which we talk as well about implementing the primary health care approach. And we're going to be hearing about, again, best practices, best strategies we learn from across the globe about implementing primary health care. We'll have a short break, and then we'll have a panel, and we'll have a very lively panel of countries that together with Spain, Finland, UK, Netherlands, and Slovenia, they are countries actually that when you look at the rankings, and I don't like to talk about rankings, but when you look at the performance of PHC, at the full front with Spain of best results. And we want to hear why, how they have addressed some of these areas, as I mentioned, public health, integrated care, skill mix, resources, how they have addressed that, what is the key element of their success, and how are they, of course, addressing the crisis. So we will have, for those online, for those here, you have microphones, although we'll ask you 30 seconds interventions because we have very tight schedule and I'm already wasting some of the time by talking too much. And we will have as well, moderators online will be responding to your questions and worries and concerns, and will reflect your views online to the overall panel and the speakers to respond. So now I'd like to introduce the really key protagonists today in this meeting. So I'd like to ask Soraya Dalil, the head of the Primary Healthcare Global Program in WHO Geneva, to take the roster, to take the roster of the podium, rather, rostrum, the podium. And thank very much Soraya, that comes with a copy of the book, of the summary, for the leadership together with WHO Euro on doing this measure report, which I understand, Soraya, is going to be the first part, the first volume of the World Health Report on primary health care of WHO. Please.
We can't hear. The microphones aren't working.
Thank you. Thank you, Joseph. Distinguished Minister, colleagues, ladies and gentlemen, very good morning. My name is Soraya Dalil, and I'm the Director for a special program on primary health care with the World Health Organization based in Geneva. And I'm very honored to be here with you today. Thank you for the invitation. Joseph started saying this morning that why now? Why we're here to speak about primary health care? After at least 45 years from the Declaration of Almata, we are yet together to uphold the primary health care. And I think it's because we are in a complex and changing world. We are in a world that faces complex realities, from climate change to population, demographic changes, epidemiological changes, and core principle into this situation is the principles that was enshrined in the Declaration of Almata and the Declaration of Astana, and they are equity, human rights, and social justice. Those principles are as vivid and valuable today as they were 45 years ago. And that's why we have come together to look into primary health care in Spain, in Europe, and from my perspective also from a global lens. I would like to thank Spain, the Ministerial of Spain, for championing primary health care. I think that championship and being the spokesperson for primary health care at the national level, regional level, but also showing results for the population is the key to making primary health care happen and to make it evolve with the evolving situation. So, Dr. Tedros, Director General of the World Health Organization, last year in September during the United Nations General Assembly in New York, said that primary health care is one of the most important concepts in public health, and also one of the most misunderstood concepts in public health. This is true, this is unquote. Yes, I think that's true, and that's true even within the public health community. Many people continue to interpret primary health care as referring exclusively to primary level of care. Primary level of care is the defining feature of primary health care, but it's not all of it. It's also about communities' empowerment and engagement. It's also about the determinants of health, the multi-sectoral policies and action that drive ill health and drive inequalities and so on. So the primer that's why I'm here to introduce is about implementing the primary healthcare approach. It brings implementation lessons from 50 countries from all over the world. The primer was written by a group of around 70 authors, researchers, intellectuals, academia from around the world, from all 6 regions of the World Health Organization. So, what I would like to say here is also to remind ourselves of the commitment that the member states did in September in the UN General Assembly in New York with regards to universal health coverage. And they reaffirmed that the path, the road to universal health coverage is primary health care, which means that we cannot achieve, no matter in which socioeconomic context we are, cannot achieve the universal health coverage unless we seriously implement the primary health care. So there is need to have big and bold decisions on primary health care. It's not only technical solutions, it also have a political decision makings. It's about the politics of resources, who gets the resources, where they get the resources, and how to maximize the level and the distribution of health and well-being across the nation. So to me, I would like to remind all of us that it's about primary health care, it's about progressive realization of health and equity, health and well-being, and its equitable distribution across the population. And I think that's important because Spain, with all the history of it, with being champion for primary health care, now takes the stock and say, so what's next? What we have done, what is next for us, how we take it to the new level, to the 21st century, to this complex world, to the increased demand, also to the limited resources that the country has. So, for who this book is, this book is designed for a variety of audience and readers, researchers, public health decision makers, planners, managers, leaders in the Ministry of Health and in the government, but also very importantly to students and to the young generation. I would like to stress on that because undergraduate education has, in most of the countries, primarily focused on secondary and tertiary care, with hospital specialists teaching almost all clinical subjects, with almost no practical training at the primary care level. This has happened to me when I went to medical school, and probably to many of you who went to medical school or you went to health sciences. So in terms of the exposure and opportunities to learn at the primary care level, that restricts students to access opportunities and to develop interest in primary health care. And also for primary health care physicians and clinicians to pursue teaching career and of course to pursue research opportunities. And I think bringing this together and bringing the young students, the undergraduate education closer to primary care will also attract some of the young talents to come and to become our future health workforce. What is next? Why this is called primer? If it's called primer, so there's something also forthcoming. Forthcoming is another global report that will look into performance and capacity of primary health care at the global level. That gap exists. At the global level, we don't have any reference on the performance and capacity of primary health care, and that's what we are working with the WHO regional offices to produce that report. Upcomings are also PHC country case study compendium. We have collected around 300 case studies from countries to showcase primary healthcare implementation. We have cataloged them using a web-based engine, and they will be available in May 2024. That is searchable based on various criteria: source of publication, geography, socioeconomic context, levers of the PHC operational framework, like from health workforce lens, from technology and digital technology lens, from governance and financing lens, from community engagement lens, from health information system lens. So that around 300 country case studies are upcoming in May this year. Number two is also a PHC Global Leadership course that we developed with WHO Academy, and that's about leading the change and managing the change with regards to primary health care. And number three is PHC Implementation Solutions. Implementing PHC is inherently a political decision. It's a political process because it's about resources. Who gets the resources, why they get the resources, when they get the resources, and all of that. So in that, from a political economy lens, we made a deep dive to a few countries on see how to document the political economy of PHC implementation. We called it Implementation Solutions, and that's also going to be published soon with a series of webinars towards the end of the year to disseminate and to discuss the implementation solutions. With that, I stop here, and thank you so much for the opportunity. I look forward to the deliberations.
Thank you. Thank you very much, Soraya, for already opening some of the key issues we're going to be addressing in detail today and giving us the way forward, and for the very exciting resources and support that you're putting together at the WHO headquarters. I'd like now to introduce Hans Kluge, the Regional Director of WHO, who couldn't be here today, but has been recently in Spain and is coming back very soon to give us his welcome address. Hans.
Dear Madam Minister, colleagues and friends, sincero agradecimiento, my sincere gratitude to the Ministry of Health of Spain for hosting this symposium on primary healthcare, a gathering of profound significance far beyond the WHO European region. For decades in Spain, primary healthcare has played a vital role in achieving good health outcomes. Spain's pioneering efforts in translating the Alma Ata Declaration in the late 70s into action are exemplary. How PHC has been implemented in Spain is a template not only for Europe, but for the PHC community globally. Some data that speaks to the strength and evolution of the Spanish primary healthcare. During the pandemic, teleconsultations at PHC level increased by 600% and home visits rose by 4%. Spain is among EU countries with the lowest age-standardized admission rates for heart failure, with 157 admissions per million population, well below the EU20 average. Primary healthcare, however, here and elsewhere in the past 2 decades has shown signs of fragility. PHC systems globally are at a crossroads, driven by changes in demography, population needs, expectations and innovation. The COVID-19 pandemic made this even more evident. I am nonetheless confident that Spain will continue to lead when it comes to primary healthcare, building on its strong legacy. Today, we celebrate the launch of 2 publications, the case study of Spain's primary healthcare transformation and the primer on implementing the primary healthcare approach. I'm sure both will become reference publications for WHO member states. Both will serve as compasses for decision makers. The case study will fuel a national dialogue and provide a valuable snapshot of the Spanish model to international audiences. This is a comprehensive analysis of the current state, performance, challenges and opportunities. The primer, on the other hand, is a global study that collates evidence on PHC-oriented systems, covering foundational aspects, historical context, and conceptual frameworks. It delves into implementation strategies across 7 sections and performance impact. As I stated, all countries are facing challenges on this front, which is why today's symposium is so vital for sharing evidence and strategies for strong PHE performance and translating them into specific policy actions to enhance development, sustainability and resilience. When our ever-changing reality is characterized by multiple overlapping health crises and emerging health threats, our health systems need to adapt. Today is an invitation to do so, to forge pathways amid these challenging times towards equitable, resilient, up-to-date healthcare systems. In the words of Spanish poet Antonio Machado, "Caminante no hay camino, si hay el camino al andar." Wayfarer, there is no way. Make your way by going farther. Gracias. Thank you.
Se hace camino al andar. Indeed, it's very, very good. For those who don't understand Spanish, we do build our path as we walk, and very much reflects primary healthcare. Brilliant as always, our regional director. And now, no less brilliant, I'm very, very pleased. Muchísimas gracias, Ministra, por estar aquí. Thank you very much for being here, Minister Garcia. If you want to address the group, please.
Sí. Welcome, everyone. It's an honor for us to host you today in this symposium of primary care. Buenos días, directora del Programa de Atención Primaria de Salud de la OMS, Soraya Dalil, director del Observatorio Europeo de Sistemas y Políticas de Salud, Josep Figueras, autoridades, expertos, amigos y amigas, bienvenidos y bienvenidas, y muchísimas gracias por asistir a una jornada tan especial en el Ministerio de Sanidad en la presentación del estudio de caso Transformación de la atención primaria, desafíos y oportunidades, y me encanta el subtítulo, de España a Europa. Me gustaría expresar mi más sincero agradecimiento al Centro Europeo de la OMS para la atención primaria de salud, a la Oficina Regional de la OMS para la Unión Europea y al Observatorio Europeo de Sistemas y Políticas en Salud. Ha sido un trabajo de colaboración con este ministerio, el cual agradecemos enormemente. También quería agradecer, como no, aquí en España tenemos un sistema descentralizado en nuestras comunidades autónomas, en nuestras regiones, y quería extender mi agradecimiento a todas las comunidades autónomas y, por supuesto, a todos los profesionales sanitarios que han trabajado en este papel crucial en el proceso de la recogida de la documentación. No cabe duda de que España es un país de referencia en la atención primaria y que servimos de espejo a muchos países que quieren avanzar hacia sistemas de atención primaria más robustos y más eficaces. Como ya se ha dicho, la evidencia científica, desde aquella conferencia de Alma Ata, demuestra que los sistemas sanitarios más robustos y más resilientes son aquellos que tienen una atención primaria fuerte. Nuestras fortalezas aquí en España sí lo atestiguan: la universalidad, la equidad, la gratuidad del servicio, la orientación comunitaria, la descentralización, la digitalización y unos equipos muy sólidos multidisciplinares son la viva prueba de este liderazgo, que tiene su traducción en una de las tasas más bajas de necesidades insatisfechas de atención médica y de ingresos hospitalarios evitables de toda la Unión Europea. Sin embargo, teniendo estos datos, teniendo esta robustez, teniendo estas fortalezas, tampoco cabe duda de que nuestra atención primaria tiene retos y desafíos pendientes desde hace décadas y, en particular, tiene que afrontar y recuperarse de aquellos recortes de la última década, sumados al duro golpe de la pandemia, que ha dejado una atención primaria más debilitada y unos profesionales que están más bien sumidos en el pesimismo. Hoy que la pandemia vuelve a ser portada aquí en nuestro país por asuntos completamente lamentables y execrables que tienen relación con la corrupción sanitaria, creo que es el momento de recordar, nunca está de más recordar, reconocer y agradecer la enorme gesta que realizaron todos nuestros profesionales sanitarios durante la pandemia y, en particular, los profesionales de atención primaria. Para ilustrar esta importancia durante la pandemia, quería referirme a un caso particular y a una anécdota personal. Durante la pandemia yo estaba trabajando en el hospital y me llamó una compañera, una colega, porque su hermana pues tenía síntomas de la COVID y no sabía si tenía o no tenía que ir a la urgencia. Yo hablé con algunos de mis colegas, alguno es hoy secretario de Estado de este Ministerio de Sanidad y me dijo que hable con su médico o médica de atención primaria porque él o ella va a saber por la voz si tiene o no tiene que ingresar en urgencias. Es a través de la voz, a través del conocimiento de esa persona, a través de la intuición, del conocimiento y de la sensibilidad de los médicos de atención primaria, la manera en la que pudieron identificar si la persona respiraba bien, hablaba bien, con una buena cadencia, con un buen timbre, si necesitaba o no ingresar en un hospital. Efectivamente, la hermana de mi compañera acabó ingresando en un hospital y le fue bien, pero todo fue gracias a la identificación y el diagnóstico a través del teléfono. Esta es la importancia de la atención primaria y esta es la importancia de nuestra atención primaria que constituye uno de los pilares fundamentales de nuestro Sistema Nacional de Salud, que a su vez es uno de los pilares fundamentales de nuestro estado de bienestar. Ya sabemos que la atención primaria es conveniente para la sociedad, ahora necesitamos trabajar para hacerla atractiva para el paciente y gratificante para el profesional sanitario. Y para eso necesitamos garantizar tiempo del profesional sanitario. No asumir como algo normal que los médicos de familia estén viendo pacientes cada 3 minutos o que eso se convierta en una especie de pasapalabra o call center en el cual no pueden dedicarle la atención. Porque ver a un paciente crónico complejo, a un paciente pluripatológico, requiere tiempo. Porque ver y identificar a una mujer que está siendo víctima de violencia machista requiere tiempo. Porque ver a un enfermo paliativo requiere tiempo. O porque ver los inicios de una enfermedad o un trastorno de enfermedad mental requiere tiempo. Y aquí me quiero referir también a una anécdota personal de una compañera que escribió un libro que se llama Los días iguales, que hablaba de su propio proceso de depresión, de una depresión mayor, y que decía en uno de los párrafos, decía: una de las cosas que más me sirvió fue cuando fui a ver a mi médico de atención primaria y me dejó llorar todo el tiempo que fue necesario. Esta es la grandeza de nuestra atención primaria y para eso necesitan los profesionales tiempo. Necesitamos garantizar la longitudinalidad, que son esas relaciones duraderas entre el médico o la enfermera y el paciente, porque está comprobado que a mayor tiempo con el mismo médico, menor uso de los servicios de urgencias, menores hospitalizaciones y menor mortalidad. Lo hemos dicho en más de una ocasión, cuando hablamos de si faltan o no faltan profesionales, nos tenemos que fijar sobre todo en qué es lo que le falta a nuestros profesionales para poder trabajar bien, para estar cómodas, para que decidan quedarse en sus puestos de trabajo y para poder retener su talento. Pero sabemos que las acciones que precisa nuestra atención primaria para paliar sus debilidades y adaptarse al siglo XXI son muchas y además están en múltiples direcciones. La accesibilidad, la coordinación con otros niveles asistenciales, la desburocratización, la cogobernanza o la financiación son algunas de ellas. Necesitamos mejorar y reforzar la capacidad resolutiva de la atención primaria para que nuestro sistema sanitario en su conjunto sea más resiliente y para que podamos mejorar el cuidado de nuestros pacientes. A menudo se dice que la atención primaria es la puerta de entrada de nuestro sistema sanitario. Nosotros consideramos que es el corazón de nuestro sistema sanitario. Por eso, este Ministerio de Sanidad está firmemente comprometido en reforzar la atención primaria, que es una prioridad que está reflejada en toda nuestra acción de gobierno. Hace apenas unas semanas celebramos una sesión monográfica con el Consejo Interterritorial centrada exclusivamente en la atención primaria, en la cual adquirimos algunos compromisos que son significativos para las comunidades autónomas. Además, estamos avanzando en la implementación del Plan de Acción de Atención Primaria, para el cual estamos trabajando en la actualización 2024-2025. Las recomendaciones que surgen del estudio de caso que presentamos hoy se alinean plenamente con nuestra línea de trabajo y se encuentran en consonancia con nuestro marco estratégico. Así que el compromiso del Ministerio de Sanidad es tenerlas en cuenta y buscar su puesta en marcha y su implementación para que nuestra atención primaria sea integral, potenciada, dignificada y respetada. Así que, para terminar, reitero mi agradecimiento a OMS Europa por la colaboración conjunta, así como a todas las personas cuyo esfuerzo ha hecho posible este estudio de caso. Estoy convencida de que este esfuerzo conjunto se traducirá en resultados fructíferos y significativos para nuestra atención primaria y, como no, para el conjunto de nuestro Sistema Nacional de Salud. Muchísimas gracias.
Wow. Wow, Minister. That was simply beautiful, and I don't like but that was simply beautiful. That was the best way for us to start this conference. You reminded us, on the technical side, we know that the systems, the primary healthcare-based systems during COVID were the most effective ones, but you remembered us about the heart and the personal experience of primary healthcare. That's what we were missing, and you brought it. And I like to echo, with your permission, it's not the gate, it's the heart of the system. I think that could be almost the core theme today. How do we make PHC, again, the heart of the healthcare system and the public health indeed? But now I'd like to introduce Melita Jakob. We've been talking a lot about your Center for Primary Healthcare in WHO Europe, in Almaty, with so many good vibes of Almaty and the declaration, to tell us about this primary healthcare analysis in Spain. Thank you, Melita.
Thank you, Josep. Buenos días todos. Es un verdadero placer estar aquí con vosotros, entusiastas la atención primaria en España y online en Europa. You will be happy to know that I'm switching to English, which I can manage better. And it's really a great pleasure for me to launch today our case study on primary healthcare in Spain. All of you can access this case study on our website, which we produce jointly with our partner, the Ministry of Health and Amsterdam Medical University. And while this case study bears the logo of WHO, indeed, it reflects your voices because in the process of the case study, we have met with key stakeholders at the national level. We have interviewed all autonomous communities. We have discussed with patient organizations, unions, and scientific societies. So what I will feed back to you today is what we heard from you, with a little bit of strengthening of the evidence. Perhaps you could pull up my slides on the screen here in the room as well. I think that could be very helpful for everybody to see. Thank you very much. So first, my presentation will echo Minister Garcia's words a moment ago. It's very important that we recognize that Spain is a very strong health system performer in Europe. These are not just words, the evidence is there. With the longest life expectancy in Europe, public health and primary healthcare action has really contributed a great deal to these results. Very low avoidable mortality reflects that primary healthcare and public health has contributed a lot to health promotion, prevention, early detection of conditions, very strong condition management. And low avoidable hospitalizations reflect that primary healthcare does have very strong resolutive capacity, particularly for chronic conditions reflected in asthma, COPD, and diabetes. And while we will see in a moment that there are some cracks, Spain still continues to display low unmet need in primary healthcare services and very low financial burden to the population. And this is due to its comprehensive service coverage and really very strong financial protection policies. As Minister mentioned, the system has very strong foundations. And there is a unique publication, which is now a little bit dated, but this unique publication compares primary healthcare systems across Europe along its main dimensions. And Spain, as you can see shaded in green color, is one of the strongest primary healthcare systems because it has inclusive, consensus-based, decentralized governance model that allows for strong national policies guaranteeing access, but localized implementation, which allow tailoring to local needs. It has a universal coverage of a comprehensive basket, which provides us with the very strong results I showed you earlier on low unmet need and high financial protection. Its foundation, its backbone is community health, family medicine, and advanced nursing roles. There are strong multidisciplinary team-based models in place, enhanced population health management, where Spain is one of the world leaders, and advanced digital solutions which support this enhanced population health management, being able to identify vulnerable and high complexity people at the community level and work with them proactively, interprofessional multidisciplinary teamwork, and patient-facing solutions for increasing patient engagement. Many of these strong foundations are described in detail in our case study because one of the objectives of our case study was really to showcase how over decades, 3-4 decades of continuous investment, continuous thinking and refinement in the model, a country can arrive to a strongly performing primary healthcare system that produces results. But we would not be here if everything was so perfect. And after this very difficult COVID pandemic, what we are seeing is that some of the strongest primary healthcare systems of Europe and of the world are facing challenges and facing difficulties. There have been gradually increasing pressures. In our rearview mirror is, of course, first the COVID pandemic, but previously to that, there was a very big financial and economic crisis, which affected some governments' ability to invest and refine and improve and adjust continuously. And let's not forget that we're living in an area where we have increasing rate of multi-morbidity and disability. We are living longer, but living with more ailments in our communities, which are not only health-related, but combined with mental health and social problems, where for the individual, it doesn't matter who delivers the service as long as it is delivered. At the heart of all these pressures that shows very strongly what's been happening in Spain, you can see in the blue line that spending on primary health care has not kept up with these increasing pressures. Spending in primary health care over the past 2 decades has remained constant. So if pressures remain constant while demand is increasing, while needs are increasing, while people begin to trust primary healthcare system due to the stories you also heard earlier, and increasingly turn to it not just for their biomedical problems, but also for mental health problems and social problems, what happens? We deliver those services at the cost, at the expense of our health workforce, and this is why we are seeing cracks in the ability of the health workforce. Health workforce, because of that, may leave the profession because the pressures are too strong. It may be that the services can no longer be provided and people will be turned away, or that we have to make the really tough choices and dilute our services instead of spending the time to go deeply into the reasons, for example, of repeated respiratory illness in a small child, we might just give that antibiotic prescription very quickly because we do not have time to inquire about the social conditions in which this child lives. As a result of increasing demand for primary healthcare services, but continued resources, we are seeing signs of increasing distress. There are indications that some of the core aspects of primary healthcare are being harmed. And while these numbers that I will show you may not be so dramatic, numbers don't always tell us the truth. We are very imperfect capturing some of these narratives. But what I'm going to tell you is something we heard from all of you in the context of our interviews. There are concerns that access, the very strong access, is being harmed, and people seeing a family doctor within 24 to 48 hours is reducing. There is concerns that people-centeredness of the system is reducing. The percentage of people feeling involved in shared decision-making in primary healthcare has increased in the previous decade, but it's showing signs of decline. And this is a clear indication of the time pressure, because shared decision-making requires time, requires discussions, requires a different approach from the family doctors than making the call and discharging the patient. There are signs that people are perceiving that coordination between levels of care is less good than it used to be. And finally, the strong backbone of the Spanish system, longitudinality in primary healthcare, is also harmed by temporary contract and the increase of tenured positions which are not linked to patient lists. If I go further and continue with the health workforce issues, we understand that it's attracting and retaining health workers to primary healthcare is increasingly difficult. There have been 220 positions unfilled to specialize in family and community medicine in the 2022-23 calls. And this again is a negatively reinforcing circle because as we hear from young graduates, their priorities may be different. They're looking for a work environment, while they may be looking for a work environment where they can contribute to multidisciplinary teams, they may feel that their training does not equip them for this. They may feel that there are not enough professional advancement opportunities in primary healthcare where they can combine practical work and academic work. And young people also emphasize the importance of having more balanced lifestyles where they can balance their professional work with other interests. We're also seeing that there is an increased reliance on voluntary health insurance. And as at a first glance, it may seem to you like a very good idea that people who can afford to pay for voluntary health insurance and private services use that, leaving more space in the publicly funded and provided services to those who cannot afford it. What we see in many countries when this begins to happen is the upper middle class, who are most able to advocate for a system. Once they opt out of it, they do not see its benefit, they do not see its strength, they're not getting the same amount of services, and as a result, we're losing some of the advocates for our strong public primary healthcare system. This is a very difficult question for which there is no obvious solution. I'm putting it out there for provocation and for perhaps a little bit of discussion and reflection in the afternoon. And as I mentioned already, the very important dimension of time, we are beginning to see that there is some decline in the satisfaction with the time devoted by family doctors to each patient. And yet, trust in primary healthcare and its health workers remains unwavering. You can see that trust and confidence conveyed by medical staff is extremely high and has not changed between 2018 and 2022, despite all these cracks that are beginning to show in the system, despite all the dissatisfaction that we have registered in our analysis. Trust and confidence conveyed by nursing staff has even increased, and satisfaction with information received by medical staff has also increased. This is a real treasure. This means that primary healthcare is more than the provider of medical services. Primary healthcare really is a pillar of communities, a cornerstone of social cohesion, and as such, it really must be treasured. I'd like to put this in context for you. The OECD carries out a study every 2 years asking people about their trust in government institutions in general. And after the COVID pandemic, we are seeing a decline in trust in government institutions. And you can see that these numbers are very low compared to the 80% level of trust I showed you for primary healthcare. Only 40% of people in OECD countries expect that the government will improve a poorly performing service. 30% expect that the government will implement an innovative idea. And only 30% feel that they can have a voice in what the government does. This is fundamentally different for what we are seeing in primary healthcare. And as a result, we have to treasure our primary healthcare systems for more than the biomedical services it provides. It is also a gateway in building trust in the broader health system and public institutions. The OECD has very recently came out with a primary healthcare specific study on trust. And what you can see here is that the percentage of people who rate primary healthcare as good, very good, or excellent, they also express general trust in the health system in itself. And that makes a lot of sense because we each have more contacts with our primary healthcare providers than we have with our specialists and hospitals. So primary healthcare is really the face of the whole health system and, if you will, the government services. Now, what are the policy implications of this glass half full, half empty narrative? On the one hand, we have very strong results in Europe, and on the other hand, we are seeing cracks in performance, worrying signs that the system is not performing as well as we would like it to be, like it to perform. First policy implication is unequivocal. We need to put more resources into primary healthcare and translate those new resources into a full range of human resource policies. This is the sine qua non. Without this, nothing else will matter. Spain has an excellent system, but it needs resources to function well. Sometimes I use this metaphor. Imagine that you buy a Porsche. You have the best car in the world, but you're not putting any gas into it. Is it going to go anywhere? So that is my metaphor for Spain. You have one of the best primary healthcare systems. You don't need to look elsewhere for a brilliant idea, for an innovation, for a new technological change, for new diagnostic, for new roles. You have your excellent system, and what you need to do is stabilize that by investing resources to it and solve the range of health workforce policies. So this, of course, means to improve pay, working conditions for staff so that it's attractive, encourage continuous professional development, engage PhD professionals in academic institutions, and progressively implement family and community nursing specialty as a prerequisite for primary healthcare practice. My colleague Thomas Zapata will speak more about these interventions later in the afternoon. The second policy implication is to reinforce the pillars of the community-facing, team-based model. This model is really a reference point for us in the WHO European region, showcasing to other countries who are only now moving towards multidisciplinarity to a team-based approach, how to do so. And the cornerstone in a multidisciplinary primary healthcare model remains family medicine and advanced nursing roles. This is core. No matter what other professionals we add to the team, this is the backbone and it's worth investing in. In Spain, you have really introduced community and family nursing in 2010, and it has garnered momentum in implementation in many areas, but it's not yet fully systematic. So this is one of those areas where perhaps more attention, more monitoring, more resources could really make a difference. Second, you can give another look in this post-pandemic period about the roles and the numbers of key team members. It's quite clear that you have very strong definition of roles, but perhaps some of these could be systematized. And it's also clear that perhaps the existing roles are sufficient, but what you need is more of them, more human bodies. A very frequent complaint we heard is professional development opportunities are insufficient in primary healthcare. The fourth area would be to continue to promote teamwork and sense of belonging. This is very important and not to be underestimated. Many countries where we see who are moving to multidisciplinary practice, they co-locate the different specialties and they expect them to all of a sudden start working together, whereas in the past they had practiced in a solo manner. It doesn't work. You have already invested in this by creating purpose-built facilities that have space for team interaction, community interaction, by creating dedicated time during the day when teams can meet, and having further thoughts, ideas, and training about teamwork and sense of belonging is very important. And perhaps the final point I'd like to say is perhaps it's time to think a little bit harder about coordination at the community level. You really excel at community-facing provision of health services, social services, and mental health services. And in some areas, they coordinated and integrated nicely, but not everywhere. And today, when there is so much emphasis on the mental health burden, and we need to step up our effort to provide physical and mental health services in an integrated manner, it's important to take a look at what coordination mechanisms exist and how they could be strengthened. And the final policy implication I would like to raise is that what we're seeing today in many countries where primary health care has been destabilized and facing pressures, it's important to rethink governance and change management levers. Perhaps you have all of them in place in a sufficient way, but perhaps it is really time to give this another push, at least for the while you're implementing intensive reforms. I will just mention a few of these. The first one is we see often that primary healthcare is not in a high enough level in ministries of health or in regional health administrations to be able to convene all the stakeholders required. They may not have a very clear mandate, or they have a mandate, but it is not explicit. At the times of really important reforms that you want to push forward, it's very important to elevate and resource a primary healthcare team that has sufficient convening power and important mandate. The second point I want to make is that if you would like to increase resources into primary healthcare, we need to go beyond this room. We need to advocate for the importance of primary healthcare beyond the health sector. We need to explain the benefits of primary healthcare as the foundation of communities and social cohesion, and why it is worth investing in to those who make resource allocation decisions. And the final point I will make here regarding governance is you have a team of fantastically trained health workers at the primary healthcare level. It's critical that we give them the autonomy and space to make decisions how to tailor services to the needs of the community they're serving. And this autonomy varies quite a bit across the country. So it's also worth another look from your side, how to encourage innovation, distributed leadership by giving space to well-trained people to act. I'd like to end my presentation with the words of our regional director, Dr. Hans Kluge. Reframing our health systems with a primary healthcare lens is not just a choice. It's a moral obligation, a prerequisite to the kind of society in which we all aspire to live, a society grounded in trust and empathy, where health and happiness flourish for all. Gracias.
Thank you. Thank you very, very, very much, Melita, for this excellent work, for this candid presentation of the achievements rigorously, as well as the distress and the challenges that primary healthcare is facing. And thank you for bringing the trust and transformation. The Ministerial Conference we organized, WHO with the Observatory in Tallinn last year, was very much trust and transformation. So that transformation of primary healthcare should be key in regaining the trust on primary healthcare, which we heard beautifully from the Minister, how central is for the quality of life of our populations. But we're running late, as always. I take three contributions from the floor of 20 seconds each. I'm sorry. Just additional contributions to that, and 10 seconds response from Melita, and we'll move on. Deepa is around with a microphone. Do I have 3 points you want to highlight? I'm giving the word only to Spain at this case, and the next session will give the word to the online participants. A very large number of online participants are today with us. Any takers? No. Sorry, maybe I discouraged you by saying that we're running late. Yes, perfect, thank you. 20 seconds, please.
Thank you, Jennifer Kloss. Can you hear me okay?
Melita, are we gaining trust? Are we really gaining trust in primary healthcare, or still people feel that they should bypass primary healthcare just to warm up? Yes, please.
Sorry, can you hear me now?
No.
Can you hear me now?
Yes.
Okay. Jennifer Klossen from the Boston Consulting Group here in Madrid. Thank you for the presentation. Congratulations on the great work. My question is about the outcomes that matter most to patients. And I'm wondering if in your study you've seen some good representation, either here in Spain or in other countries, of the best uses of patient-reported outcomes to monitor and track the improvement of primary care over time. Thank you.
Melita. Sorry? If there are other questions? Are there any other questions? So let's move forward, Melita. If you want to reflect on this point plus my point on trust. I'm clearly short-sighted today. I don't see people.
Gracias. Gracias, soy médico de familia de Baleares, he trabajado prácticamente toda mi vida en un centro de salud y hay dos cosas que he echado en falta en los discursos con los que estoy completamente de acuerdo. La primera es el proceso que estamos asistiendo en este país y probablemente en otros, que es el proceso de privatización de los servicios sanitarios públicos, que una de las consecuencias que hay es la descapitalización del sistema sanitario público y bueno, pues esto yo creo que es una cosa a tener en cuenta. Y la segunda, que yo creo que es un problema central, que es lo que está pasando con los profesionales en atención primaria. Uno de los síntomas ya se ha dicho aquí, que es el tema de que los profesionales no escogen las especializaciones de atención primaria, pero esto probablemente tiene que ver con un estado, una situación de los profesionales en primaria que probablemente están achicharrados, por decirlo de alguna forma, y esto quizá es lo más grave que está pasando en el sistema, porque recuperar el vínculo que tenía con los pacientes y el compromiso, no solo con la institución, sino con sus propios pacientes y su propia profesión, es difícil de recuperar.
Gracias.
Me gustaría algún comentario al respecto.
Indeed, so that relates, Melita, we'll stop it here because we need to keep going to the point of trust. With such a pressure and stress, how can they regain the trust with the system, and what are the data and outcomes?
Yes, so as I showed, in Spain we do not have a problem of trust right now because people really continue to trust primary health care, even despite these challenges. But this trust must be treasured and guarded and not taken for granted. I think what we're doing here today, to talk about the problems openly, to acknowledge that we're hearing the problems, seeing the problems, and to start turning them into policy solutions and commitments for making a difference is really important for keeping this trust, both of the health professionals as well as the population. So I think this is the first step. That's very, very important. And then, of course, there are very important policy levers to keep the trust. I believe one of the core components of why trust in primary healthcare is so high in Spain is because it has moved beyond the biomedical model. And it is looking at the person holistically, seeing the mental health and social problems together with the physical health problems. And this is why putting resources so that the health personnel at primary healthcare level can continue to provide this service, which requires time and energy and effort, is very important, because this is what generates the trust. So that was very good. We are seeing increasingly the use of patient-reported measures in health outcomes, and one of the studies that OECD put forward this year for their health systems conference, is in fact ending on these trust-related metrics, but they really start with some of the patient-reported health measures. And then finally, I agree with the gentleman for the Balearic Islands, I believe it was. I think the issue of divestment of public resources is very problematic, and we really need to restore this in order to preserve a well-functioning system. When people start seeking private healthcare services to replace, they get a different kind of service. It is very different. It could be very high in terms, it could have very, very high value in terms of biomedical services, but private services are typically not meant to be a center of the community, pillar of the community, and solving holistically a person's needs in terms of biomedical health, mental health, and social needs.
Thanks very much, Melita. I think that's been an excellent way to wrap up this presentation. And we'll be talking, colleagues, a lot about trust, health workforce, resources in the following panel, and indeed in the presentation of my colleague Deepa Rajan, who works for the Observatory, has been the first editor of this study that Soraya has already introduced. We want to hear more, Deepa, about the results of this study in implementing primary health care, which is made at global level, as Soraya told us, but focusing very much on the European region. Deepa.
Okay, can you hear me? Yes. Okay, so we'll, if we can have the slides, perfect. So
Microphone.
I'm going to be presenting, you heard now the evidence from Spain, and so what I'd like to, is it not working?
We don't hear you.
Is this better?
Okay.
Okay, I hope this works now.
It does.
Yes,
Go ahead.
perfect. Okay, so I'm going to, you've heard now the evidence from Spain. So I'd like to give you a sort of, let's take a zoom out of Spain a little bit and get a bit of an overview of what's going on in Europe and globally. And this is this report that you see on your screen, the Primary Healthcare Primer, or the Global Report on Primary Healthcare, which is on our website. If you want to download it, I'll give you the QR code at the end of this presentation. And so why did we do this report in the first place? Well, basically, we really wanted to understand implementation. How is PHC, primary healthcare, implemented in countries? What can we learn from those experiences? What are those enablers and strategies that really help us transition towards a system that is really more focused on primary healthcare, because we're not there yet in a lot of countries. We still need to move from the more biomedical model of care to something that is more holistic, as Melita just mentioned. And so this book has 3 parts. I'm not going to go into the details, just to say that I will be focusing here on this middle part, which is about implementation. But if you're interested, we also have the first part about history and concepts and definitions. And the third part, which I think is really key, it's the evidence on the impact of primary healthcare on many of our health systems goals, like equity, efficiency, overall health improvement, resilience. What does the literature say about that? And you can look it up on the part 3 of the book. But let's remind ourselves, what is this all about, primary healthcare? What we want to do is transform to what you see here. This ball encapsulates what we want to achieve with primary healthcare. We want primary care and public health to be at the core of integrated health services. We want more community-facing roles. We want community care to be integrated into this, and we want to address the determinants of health through multi-sectoral policy and actions. And we know that at the moment, what we have is a system that's more specialist-focused, that's more hospital-centric, and where services are organized more around the perspectives of providers rather really than the needs of the patients. And so in order to move that direction, in the direction of what this ball encapsulates, there are some key priority areas where we need to take action, and the global evidence is quite clear on this. There's a lot more that we can do, but I'm focusing on a few areas that are really key because they're relevant for the Spanish context. It comes out in the Spanish case study, and it's also, we're going to discuss this in much more detail in the panel roundtable after the coffee break. So let's start with that first topic, which is about integrating services. So what are we trying to integrate? Primary care with public health and social care and community care. And at the heart of all of these services, what we know is that the people and the institutions behind them come from vastly different paradigms. They've been trained differently, they see health differently, and so bringing together these kinds of different paradigms, it clashes sometimes, and that's really at the heart of the difficulty of integration. And what we mean by integration can be as simple as mutual awareness, which might make sense for certain tasks, but for many other tasks, it's really about collaboration and cooperation. And in some rare cases, like in Finland with the Ministry of Health and Social Care, where you have full integration of two different services, but that's actually rare. But what the country experiences and the evidence base tells us is that in order to really move towards integration, successful integration, integration examples, what they've shown us is that we need to address that paradigm issue with, for example, a clear shared vision and goals. Because those paradigms are so different, we need to invest in having people come together and actually have a shared vision that they co-own. And that means investing time in developing that shared vision and having those people come together, which is dependent on the change management approach, as Melita also clearly mentioned, is really key. Leadership that supports and acknowledges that there are different paradigms that are coming together. And this can be done through different professions. In Finland, for example, at the regional level, you have nurse managers who often take on this role to bring the different people together and to make sure that everyone is on the same page. And then more upstream, addressing those different paradigms can be done through education and training in a joint way. So we have many experiences in Europe where now we're starting to see medical students and nursing students have 1 or 2 modules together, for example, either in theory modules, but also clinical modules. Other ways to do it is dual training. For example, in Canada, there's a big push at the moment to have primary care providers have additional training in public health to bring in the population perspective along with that individual care paradigm and to bring that together. Shared data systems is obviously key because it means that you have that individual level data, but also the population level data coming together and having a shared analysis and approach to looking at this. And this can be really leveraged to bring different paradigms together. In the Netherlands, for example, you have district health profiles used to bring together public health and primary care people to discuss and have a dialogue to do joint work planning. And then you have joint funding, which can be helpful. The big caveat with joint funding is that some of these other issues that you see above in that bullet point list need to be happening in parallel, because joint funding, if it needs to be done in a way that doesn't have the perception of a competition of resources. Otherwise, what tends to happen is that most of the funding tends to go towards the more politically sensitive, public-facing areas like primary care, with less going to public health, and we'll hear about that later in the panel from one of our panelists. And so with joint funding, it's really there's a caveat there, is that it needs to be in parallel with some of the vision and the change management that we need. Now, incorporating public health into PHC with the focus on health determinants makes sense. They add value to each other, these two areas, and you can see here, health protection is a place where you have natural synergies between public health and primary care. For example, in primary care, you would address individual risk factors, but it is complemented heavily when in public health you have a constant monitoring of those immediate causes of disease, and also more upstream causes and commercial and political structures and determinants of health, even if some of those larger upstream issues are done at the national level, which we'll hear about in our panel from Slovenia, that it's more the National Institute of Public Health and the ministry that might cover that, but there needs to be that coherence between what happens at that national level and some of the monitoring at local level of those determinants of health. And so health protection is another area, natural synergies between primary care and public health with assessment of the population, including more targeted analyses for marginalized communities, which then allows primary care to have targeted, individualized advice and support. And for example, in the area of emergency preparedness and response, public health prepares community-level emergency plans, which then the frontline workers in primary care can use to respond to emergencies. So there's obvious synergies there that we need to take advantage of. But to do so, we need a workforce that is able to do that. So we need to reskill the workforce towards PhD to be able to do this, to be able to really take on those community-facing roles, for example, to really do integration and primary care, for which we need generalist skills. We know that the vast majority of our medical graduates, even if we're churning out more graduates in general in Europe, most of them are going into specializations, whereas where the need is in the generalist area at primary care. And that, in generalism, is not just an absence of a specialization. It's a specific skill set. It needs specific training, and it needs specific investment. And this is where we need to reskill our workforce and have a focus on. And unfortunately, what we've seen in Europe and globally is that, with less investment in the primary care level and in generalist skills, then quality suffers. And people start bypassing primary care. It suffers from low prestige, and there's a downward spiral, and we need to lift that up in order to get out of that vicious cycle to really make primary health care at the heart of our health systems. And there are two strategies that countries have been really focusing on and has been a priority over the last decade or two, where we have growing evidence about. And one is really this issue of task sharing or task shifting, and this is about roles that exist already and extending them to do other tasks and new tasks, but also new roles like social prescribers, like physicians' associates, for example. And the evidence is growing that for some of these really important health promotion and disease prevention tasks, we need task shifting and task sharing, that it makes a huge contribution to it. And through the community-facing roles that we have, through the task sharing and task shifting, we are better able to address health determinants and have a much stronger population perspective. So these advanced practice providers, they can provide, and this is what the evidence shows, equivalent or higher quality care compared to physicians or teams where those extended roles are not integrated into it. And while we do need more evidence on this, what we do have to date is quite clear. And really what this is about, it's about each member of the team adding value based on their specific training and skill set. So the GP adds value by doing complex cases and chronic care, and other team members add value by doing some of the more community-facing tasks. And that makes sense, and it also increases work satisfaction. It means that each member of the team is much more satisfied, and it's easier to retain them into the health system. And so these multi-professional teams is the other area where we have a growing body of evidence. We have better evidence on the positive impact of these teams in the areas of mental health and family care, or more studies at the moment. And it's a bit mixed, the collaborative practice evidence in chronic care and cancer care. However, this is largely because there's a big variation in the how of these teams and how they're established. And if you look at those how factors in a little bit more detail, what we see is what leads to better outcome is, again, we go back to this issue of the different paradigms. So structured processes that allow for those two paradigms, or three or four, to come together and collaborate better, and leadership which enables a truly collective management of patients, have better success in those multi-professional teams. And that means overcoming traditional hierarchies of the different professions, which is really key to getting that team to work together well. Finally, I'll say a few words on financing, because we do need to redesign financing mechanisms if we want to have the money go towards what's encapsulated into this ball. And so there we need to, as Melita said, allocate more money to PHC. It is value for money. The analyses for this came from the Lancet Commission on Financing Primary Healthcare, and we know that spending levels on health and PHC largely depend on wealth of the country. Perhaps we don't need a Lancet Commission to tell us that, but in any case, the variation that we see is largely based on that. But an important aspect is that at the same level of spending, we see very varying outcomes, which means that we can spend better. And spending more on primary healthcare may not necessarily, in the short and medium term, reduce overall expenditure on health, but it is clearly value for money. This is something that we do know. We know that many of the most cost-effective interventions in health can be delivered at primary care level, generating greater health benefits for each single unit of spending. So my last slide is just to say that in order to spend that money better, we need to make sure we increase access to primary healthcare. Out-of-pocket payments needs to reduce. The Lancet Commission was very clear on this, that pooled public financing mechanisms are clearly superior to private voluntary mechanisms such as user fees or private insurance schemes to strengthen primary healthcare and to increase user access. And this is because public financing is what ensures that everybody, including those who need care most, receives the health services that they need. So user charges, and there's a large body of evidence on this, are not an effective instrument to direct people to efficient health service use. We also need to reduce fragmentation of funding. We can't have providers having different sources of funding for multiple interlinked conditions, from a regional government, from a national government, from voluntary, complementary health insurance, out-of-pocket payments. It doesn't incentivize integration of care. And finally, we'll hear about this on the panel as well, needs-based resource allocation mechanisms are really important. What we mean is that, and this is complicated to do in practice, perhaps easy in theory, it's about understanding the risks of ill health in our population and trying to target equal resources for equal need. And we can see across Europe that this is still not the case, and we'll hear about it also in our as I said, in our panel, that lots of resources are still going to the more affluent areas and communities, and this we do need to change. It's something that requires a better understanding of people's needs, where engaging with citizens and communities can play a key role. So to end, I'd just like to remind ourselves that this is the promise that we'd like to fulfill. This is what 1978 Alma-Ata told us and was reaffirmed in 2018 in Astana. And you can download our book with this QR code, or just check our website, European Observatory on Health Systems and Policies. It's also on the WHO website for the global report on primary healthcare. Thank you.
Thank you very much. Please, the slides, could you put the slide of the download of the volume, please? Stay there, Deepa. Thank you very much, Deepa, for the effort to summarize what is the work of this measure volume, of this measure study in so few minutes. So it's an appetizer. Now it's online. You can download it. If we can see the code again, you can download it. It's easy to find in our website, on the WHO website. So if you could put it back, please. So any views, reflections from our online participants? I'd like to introduce now José Cerezo and Ángel González, who have been beautifully following the debate out there, responding to the questions, and now they give us a sense of the temperature out there. Are we getting lots of funds, lots of support?
Of course, of course.
Thank you.
Very active discussions indeed. Thank you, Josep, for the word. There is one about something that has been discussed also by Melita earlier, but is very relevant now as well, is given the impact of the demographic changes and the shifting in expectations as well by patients and communities, how do we manage these growing expectations that citizens have? And related to that, how do we avoid getting into the trap of having a supply-driven demand in the primary healthcare system and the health system in general? That's one, and my colleague Angel has another interesting one as well.
Okay, thank you, Jose. So we could see in Melita's presentation that there were 220 positions unfilled to specialize in family medicine in 2022 and 2023 in the MIR calls, our national examination that we have in Spain. And Alberto Núñez posted in the chat a question that is very relevant to me, being a Spanish family doctor as well. And it's what are the main factors that will boost interest in primary care among medical students? Understanding those factors will help in attracting them as general practitioners. Thank you.
Actually, it's very well, congrats, very well chosen two questions because are at the core of these challenges. Please, for primary healthcare. Microphone.
There we go. Okay, so let me start with the last one on attracting medical students into primary healthcare. And we actually have a policy brief on this, which you can find on our website, and then a second one that's coming out this year. And so what we really saw in that analysis is that, in places where salary levels are on the low side, building up, lifting the salary level does help, but beyond a certain salary level, it's not the salary that's the most important. It's really many other working conditions that are key to really attracting people into primary healthcare. And these are things like teamwork that actually increases work satisfaction, allowing people to work in a team-based environment, allowing modalities to have better work-life balance, for example, helps to bring people into primary healthcare. And in terms of medical training, and I mentioned it earlier, is joint training with other professionals can be motivating, and also much more exposure to family medicine during medical school. We know that the vast majority of medical school time is spent, unfortunately, in learning about specializations, and not enough time spent in practice, and not enough time spent learning about generalism and generalist skills. We train our medical students to work in a hospital, high-tech environment, whereas the need is actually in a lower-tech primary care environment. So that mismatch needs to be better aligned. The other question, remind me again, was on
the pressures, right?
The pressures of primary healthcare.
How to manage the demands driven by shifting patient expectations on primary healthcare.
Yes.
And yeah.
Best expectation.
Yes, and I think this is something which, yes, we heard also from Melita. Often the high demand and expectations in primary healthcare actually comes because the system has been strong in primary healthcare. In countries where primary healthcare has been traditionally less strong and weak, people's expectations are actually not that high. So this is something, in Spain and in other countries, you enjoy high expectations because you've been used to strong and good primary healthcare, and there's no way around it. We need to invest in primary healthcare at the moment. We need to invest in those multi-professional teams, in a lot of those community-facing roles, in getting in more and different professionals and specializations to work together with the family doctor. The family doctor cannot do everything, and the family doctor should be focused on the added value he or she can provide, and many of those demands and expectations of people can be met by others in the multi-professional teams. And here also digital means is also a good way to respond to people's needs and expectations, because many of the the questions and the issues that come up are not necessarily something that needs a personal interaction. And this is where we've learned there's a lot of good experiences from other countries, and we might have some time to discuss it later on in the panel.
Indeed. Actually, these are perfect questions, perfect areas to highlight, because that's exactly what we're going to do in the panel. In the panel, we'll hear about how do we make a case and increase more resources for primary health care. We're going to talk about the health workforce crisis and the skill mix and the need to widening those skill mix in primary health care. We'll talk about integration, integrated care, coordination with hospitals, and we're going to talk about embedding further public health into primary health care, and very much from the perspective of countries with successes as well as challenges, but successes in each one of these areas. So in a minute we'll have Finland, we'll have the UK, we'll have Slovenia, we'll have the Netherlands, and we'll have the European Commission to reflect on the broader perspective, as well as Spain in there of public health. So come back, I'll give you 20 minutes of a coffee break, a human right today, a hot coffee break. Please, but we'll start in 20 minutes, really, 12:15, on time for the online, be here, please. It's really, really exciting, concrete, specific, what member states are doing. Thank you very much indeed.
Please take your seats.
Por favor.
Please. ¿No se escucha? Por favor, id sentándoos. Vamos a empezar.
Ajustense los cinturones que vamos a despegar.
Sí, más o menos.
¿Estamos ya?
We will now move on to the next session, which is a panel discussion focusing on the perspective of different European countries, entitled From Spain to Europe, Primary Healthcare Reforms. Over the next hour and a half of esteemed panelists will explore this important topic. Our moderators for this discussion are professionals with extensive knowledge and expertise in the field. First, we have Dr. Pilar Aparicio, who serves as the coordinator of health strategies within the Quality of Care Unit of the Spanish Ministry of Health. She will be joined by Dr. José Figueras. I will now give the floor to both of them. Thank you.
Thank you, Marta. Well, good morning, everybody. It's a great pleasure for me to participate in this important event to focus on primary health care in Spain, from Spain to Europe. It's also a good opportunity for all of us that we share this session with so important panelists and also the public that we will share with them all the questions about with the survey. The objective of this panel is we are going to focus especially in how to incorporate public health in primary health care and how to strengthen the idea of the importance of the inequities, how primary health care can solve this question, with a different experience in the different European countries, and to show how these experiences can be helpful for all our countries. Joseph, please, can you open the dialogue with the...
We'll start by realizing our democratic right to vote today, here in the room through the Slido and also online. So if I can have the question that we're going to start discussing today, Jora. So the first question is, well, it's not rocket science that core to the effectiveness of primary health care is the integration of public health into primary health care. And yet, there is limited progress. A lot in some countries, very little in many others. Why is that? So we're asking you to choose two reasons, two responses, considering your country experience. I'm not sure you can see it well. Yes. I hope you all can see it online, and you can see it here definitely. So please go to the Slido, #APS, and these are our answers today. PHC and public health have developed as separate. They are like two strangers in the night, dimly aware of each other. Okay, we're getting results here. Good, good, good. Lack of time. A statistic, part of the research we did in that volume we presented is that if doctors had to do public health as well as care, they need 70 hours more per week. Overload. I'm provoking you a tiny bit, you know that. Primary healthcare staff are not trained and sometimes not even motivated to work on public health. Public health in many countries is not geographically primary health care in many countries is not geographically population-based because patients can choose their GP practices, their family practitioners in different geographical areas. And for public health to be effective, we need to have a geographical, clear population-based limitation. Primary healthcare organizational models and mandate are not really conducive to integrate it with public health. Again, the organizational approach is very, very different from that of public health. And now I'm going to provoke you. Primary healthcare has no role in addressing social health determinants. What's primary healthcare to do with social determinants? Do we agree with that, Jan? We have today Jan de Massener here, which is a real pleasure to welcome you. You've been the father and grandfather and the young man leading a lot of this work in this field. Not relevant. Public health is effectively integrated into primary healthcare in my country. So there's 6% that they're very happy. It's happening there. Is it the Spanish are saying that? Who's saying that? Okay, so we're getting votes here. Clearly, Pilar, what do you think about this? Join me more further here.
Well, we can see now, we are just, the first thing is just to understand what all the participants are answering these questions. And we see the main worry about how public health and primary health care are separate disciplines. What is one of the, I think, is a good problem to start asking also Pedro Guillón, the currently Director General of Public Health and Equity. Pedro, what do you think about it?
Well, first, thank you very much for having me here. You can imagine that it's a real pleasure being here. And as this is my home, I switch to Spanish. Yo creo que refleja muy bien lo que piensa verdaderamente gran parte de la población española, entendida sobre todo por los profesionales de la salud. Las disciplinas de atención primaria y de salud pública han estado separadas en sus programas formativos, aunque luego puedo hablar un poco de cómo en realidad están más juntas de lo que parece. Y el tiempo, desde luego, es lo más relevante, ¿no? Hacer salud pública desde atención primaria o hacer salud comunitaria desde la salud pública es algo que requiere mucho tiempo y, por lo tanto, no es fácil de conseguir cuando hay una gran presión sobre los profesionales. Y a mí lo que más me interesa es el porcentaje más bajo que hay sobre que no tiene ningún rol en los determinantes sociales de la salud, porque creo que sí lo puede tener y puede tenerlo aún más importante.
Taking into account your extensive experience in how the social determinants directly affect people's health, how do you think that we can, to achieve also universal health coverage and equity, which is the role of how to address effectively health inequities from primary health care?
Gracias, Pilar. La verdad es que como yo vengo del mundo del mundo académico, me gustan mucho las clasificaciones y estudios previos. Las desigualdades en salud están presentes en todos los países y en todos los contextos, pero no son iguales. Un estudio muy famoso hecho a nivel europeo, que fue liderado por Mackenbach, estudió las desigualdades en mortalidad por nivel educativo y se daba lo que se conocía como la paradoja mediterránea. Resulta que España era uno de los países con las desigualdades sociales en salud más bajas, al menos en mortalidad por nivel educativo. Y mucha gente en aquel momento se preguntó, quizá, aunque los determinantes sociales de la salud se encuentran normalmente fuera del sistema sanitario, las características propias del sistema sanitario español y especialmente de atención primaria pueden jugar un rol para que las desigualdades estén frenadas dentro de nuestro Estado. Por lo tanto, tenemos ahí algo muy interesante, porque se puede hacer desde muchos ámbitos, ¿no? Si entendemos la salud pública como todas las acciones colectivas que hacemos para mejorar la salud de la población, la salud comunitaria es básicamente las acciones que hacemos para mejorar la salud de la población en un contexto muy concreto, en un contexto integrado. En ese sentido, y como dice Carlos Sobrino, que es una persona que ha trabajado mucho en los modelos teóricos de acción comunitaria en salud, puede haber 3 lugares desde la atención primaria de los cuales se puede hacer atención comunitaria. El primero, que es directamente en la consulta, utilizando una mirilla de determinantes sociales de la salud. Tú en tu consulta puedes utilizar los códigos Z, que sirven para denominar condiciones que no son específicamente salud, o teniendo en cuenta atención diferencial en función de los contextos de cada persona. El segundo nivel, que es hacer trabajo grupal, que es trabajar de forma conjunta con otros actores y con otras personas que son comunitarios. Y luego un tercer nivel, que es pensar que el centro de salud no es el único centro de salud. Es decir, que podemos encontrar centros de salud en cada centro que se hacen cosas a nivel de la comunidad. Y creo que en esos 3 niveles podemos hacer diferentes cosas para que el sistema sanitario y específicamente atención primaria pueda reducir las desigualdades sociales en salud.
Thank you so much, Pedro. I think, Josep, we can follow the different questions that you asked.
Pedro, what did you vote?
I didn't vote. It was impossible for me. No. If I have to vote right now, so si tengo que votar ahora mismo, yo diría que el principal es el tiempo, incluso por encima de la separación de disciplinas. Diría por una razón, la separación de disciplinas es real, o sea, los itinerarios formativos de atención familiar, de medicina familiar y comunitaria, que tiene ese apellido en España, y de salud pública, están diferenciados. Pero después somos un mundo pequeño y estamos bastante integrados. Si miramos la gente que aquí en el Ministerio, por ejemplo, hace los planes de salud comunitaria o la estrategia de salud comunitaria y que trabajan en promoción de la salud, la mayoría tienen un pasado de atención primaria. Y están dentro de salud pública.
It's really, we'll now move to English. So it's really, it's really interesting. We saw that a lot of our online voters talked about these separate worlds, talked about the lack of aligning of organizational models, right, Pilar? While here in Spain, would you agree with that, Pilar? The view is less, the model is there, is working, but there's no time or resources to implement that model. Is that so, Pilar? Actually, I'm talking with the two Director Generals of Public Health in Spain. The living one, been here for many years, leading a lot of the work in public health and primary care, and the new one with the new administration. Pilar, would you agree with that?
Yeah, no, I agree, of course. And I think, and it's also a question to Pedro, because we have done some steps, not enough, but some steps, very important ones. And I think one of the most important steps was to create the specialty in family care and community care. These words, family and community, is very important also for medical and for nurses. What do you think to how we can go further? Because this is an important step to have these two specialties, but how to go further in this common sense?
Yo creo que para ir más allá hay cosas que podemos hacer nosotros y cosas que, por desgracia, no podemos hacer nosotros. Empezaré por las que no podemos hacer nosotros. El origen de la salud comunitaria en España y el por qué fue tan fuerte es porque había también un nivel comunitario general muy fuerte. Estamos hablando del crecimiento en los años 80, de todos los movimientos asociativos, de todo el movimiento que había en la calle. Todo eso estimulaba a que hubiese una acción comunitaria en salud, porque había acción comunitaria. Ahora los tiempos que vivimos son más difíciles, ¿no? Con mayor precariedad y con más dificultad de tiempos para poder hacer acción comunitaria. Entonces hay un tema en el que nosotros, nuestra labor es acompañar a que existan procesos comunitarios, que ya es mucho de por ahí. Y luego lo que sí que de verdad podemos hacer como ministerio, que podemos hacer como administraciones públicas en trabajar en ello, tenemos que trabajar por una parte para que programas formativos puedan estar más integrados, incluso, bueno, pues se hablaba antes de la experiencia de Finlandia, la presentación anterior, donde profesionales de atención primaria pasaban tiempo en salud pública. En salud pública tenemos que pasar una parte en atención primaria cuando hacemos la especialidad, pero a lo mejor se puede integrar todavía más, y después a lo mejor programas, una vez se está trabajando, programas de integración, conjuntos, proyectos que podamos impulsar, que sean conjuntos, etc.
Perfect.
Thank you.
Thanks very much, Pedro. Thanks very much, Pilar. Let me now move to Slovenia and to a great colleague of ours, Vesna Kerstin Petric. Vesna, you've been there. When I have to introduce you, I don't know what how to introduce you because there are so many things I like to say about you. But one is, I think, you are a public health activist in Slovenia, in Europe, and internationally. You were chair of the World Health Assembly of the WHO Executive Board. You've been playing key international roles as well as Director General in Slovenia and more recently leading the coordination between WHO and Slovenia. Vesna, did you vote there? Put your microphone. Were you one of the votes that said everything is working well in Slovenia? Because I have you here to prove that, to tell us the best practice. Did you vote that? What did you vote just now?
Well, actually, I didn't have a chance to really vote, but I did, not by phone. I would describe me in this context more as a person who has worked at the Ministry of Health for almost 30 years. I'm a medical doctor, I'm a public health professional. But have worked in very many areas and also internationally. I have been, as you said, very active, so I could see other countries also. And what I think is really important is continuity, and to have some people there, you know, who take care of continuity. So I hope I'm a person that is helping my ministry to have some continuity there. When
Are you
I'm
saying, Vesna,
this,
let's be blunt, are you saying that the political changes in ministries make it very, very difficult in a staff to continue with policies? Are you saying that?
they do. And I was saying this with a purpose, because I don't think there is such a problem having separately, you know, public health and primary health care. If you invest, as we did, long-term for more than 20 years, to get them together, to make sure that they understand that they have same goals, to make them work for the same vision, you know, and to allow them to pilot innovative approaches, models, projects together. And this is, you know, how this is crucial, to enable them to work together.
Let's talk about that, Vesna, exactly that. Because you saw our online and people in the room said the problem is the organizational model, the not alignment of objectives. Can you tell us this concept, you call it health promotion centers, I believe, within primary health care. That's been key, right? What is that? What is promotion centers inside primary health care? What does that mean?
Actually, what we could see was what everybody has seen already 20 years ago, that, you know, we have rising burden of non-communicable diseases, and we were really thinking what could be done. And we understood that with public health policies, you can do something, you know, tobacco control and these kind of things, but you also have to work with people individually, smoking cessation programs, advising them on obesity and things like that, you know. So where would this be placed most appropriately, if not if a primary healthcare center that is based locally and that is serving population, you know, throughout the lifespan, actually, very near where they live. So we decided to develop health promotion centers within primary healthcare centers and make sure that there is appropriate team there. So doctors could refer their patients to people who know how to deal with, you know, physical activity, dietitians, kinesiologists, mental health professionals, and so on. That was the team there. And these centers have worked fine, but after 10 years, we evaluated the impact of these centers, and we were astonished. People attending those services that were free of charge were early retired women in their early retirement who already took a lot of care for their health, not people that were really, you know, having difficulties with their nutrition, poor people, ethnic minorities, Roma population, for example. These kind of people didn't attend. So we looked at it and we said, what's going on here? You know, why don't they attend services free of charge that are there locally for them? And the answers were very simple. I don't think I'm educated enough to attend, you know, or maybe I don't even know for this program, nobody told me, or maybe I'm old and, you know, it's difficult for me, I don't have a car and the license anymore, it's difficult for me to go to this center and attend those programs every week, you know, these kind of things. So multidisciplinary team there, you know, didn't really reach the patients. So we had to upgrade those centers. And I would like to share with the audience that this means investments. We invested a lot of resources here. We went for Norwegian funding, for the funding of European Commission, the colleague is here, you know, and we wisely used those resources to further develop public health promotion centers and their role in the community. So if you want me, I can continue a little bit, but I think I said enough so far.
Vesna and I know each other very well. We've been in this debate several times, and I love to work with you, Vesna. Vesna, another element that I'd really like to hear, and that's exactly the way I want you to go, but I wanted to introduce it a bit more. Deepa Rajan was reminding us that one of the 3 pillars of primary healthcare is community participation. Easy to write, easy to present, easy to believe on, but very difficult to do, as Vesna saying to us. And you, Vesna, now in the World Health Assembly, you are living a major social participation leadership initiative, a new resolution. Why is it so difficult to go to the communities? Why is it so difficult to go to social participation, to civil society? You said it beautifully. You have these centers, these health promotion centers, no one goes there. So you said, I have to go out. Why we're not involving the youth? Why do we involve the vulnerable? You've been championing that massively. And I'd like to go back to you, Pilar and Pedro, briefly about how do we do that in this country?
You see, it's important to understand that nothing just happens, you know, especially not if you put it in a book. You know, this is very motivating. It's a great book, it's great vision, you know, but you have to implement. And to implement, you have to have government there that makes this decision and invests. As I said before, there were investments, not investments just, you know, investments in training for professionals.
Social participation, it's believing in civil society. That's what I want to hear.
No, this came out of necessity. It didn't come out of believing in anything. But when we realized that we cannot actually reach out appropriately to the most vulnerable group, that we know nothing about their needs, that we cannot even appropriately address their needs because they don't come, you know, we realize that there are entities in the society, in the community actually, that do work with them on the daily basis. So why not to work with them, join our forces and get the services there and make them appropriate for these specific groups, like drug users, for example, or any other group, Roma population, you know, or even individuals or the families with obesity problem. So we developed a system where in the community, in the lead is Health Promotion Center. But the Health Promotion Center works at the community level and they develop together an action plan with social services, with NGOs, with school sector, with the administration of the municipality, and everything is based on something very precious. These are municipality health data provided by public health. To them, so that what they do is most appropriate for their municipality or community.
So the data, the support to understand these populations is fundamental for PHC. Very briefly, either Pedro or Pilar, very briefly, how do we do that in Spain? Are we outreaching to communities as well?
No tanto como nos gustaría. Nos gustaría mucho más. Hay experiencias concretas de algunos lugares donde han desarrollado, en Madrid, por ejemplo, en la pasada legislatura del Ayuntamiento de Madrid, existieron centros que llamaron de salud comunitaria, que eran centros específicos dedicados a salud comunitaria, que tuvieron lo que a veces no se tiene en los centros de atención primaria, que es tiempo y una dedicación para poder coordinar acciones comunitarias. La verdad es que es una experiencia muy buena y en el informe del Case Study tenéis otras experiencias muy buenas de salud comunitaria que se han desarrollado en España en diferentes comunidades autónomas. Pero, sobre todo, más, nos gustaría más.
Perfecto. You want to add anything, Pilar?
Just to add, I think the strength of our system is that it's a model based on primary health care. And this is not only just a theoretical question, is that there are so many centers based near the population, where families live, that this is very important to create this kind of connection and proximity with your family doctor, with your nurse, etc. Then, as Pedro said before, we need the health workers need time to do the work, but the continuity and also this work that was so useful when we discussed with Melita and the team about this longitudinality of the care. This is so important to do this approach.
Time and resources, what Spain wants. And I'll ask the last part of these panelists to talk about a lot of time and resources. But let me introduce Tina Hetema from Finland. Finland has been our role model, Tina. It's been our role model for many years. And now more than ever, because you're not talking about health anymore. We're talking about well-being. Well-being is not just health. It's many other factors. The Finnish presidency of the European Union, that the Observatory was very proud to be involved with as well, touched on well-being, not only health as being core and important, but other actually or the development goals of society, education, poverty, gender equality. And what I love about your system, and I want to hear whether it's true or not in practice, is that you seem to work together now with these reforms on these well-being services, taking very much what Vesna is saying, what Pedro and Pilar, and actually integrating them. Why the Finns manage to work with social and education and all well-being together? What's the secret? It's because you're Finnish, or it's because you have organizational mechanisms, is your culture that we can never repeat, or it's because you have organizational mechanisms and incentives that the rest of us here can learn?
Okay.
How these well-being countries look like?
Okay, thank you. This is my first time in Madrid, and I'm already loved. Thank you for having me here. First, I have to point out that our new well-being services counties are self-governing, and each of those, they have their service organization built from its own starting points. But still, there is a structure that supports this integration. It's recognizable. It is often some kind of a life cycle model. There is services for families, there's services for elderly, and then there are social and health services. And in some counties, if you think about the mental health and substance abuse services, they are located in health and social services, but in other counties, they are part of family services. Does that make any sense? If you take a child that has a problem, the root cause of the problems might be with the parents, substance abuse or alcohol problems or something. So the coordination is much easier if they are together.
So it's geographical location together that makes a difference?
They have both geographical, or they have the same building, or they have networks. So it can work both ways.
How these networks work? Because we all love to be the bosses and the leaders. Look at me, I like it.
Yeah.
So who's the leader of these well-being services? Or there's no leader, it's an equal partnership between education and social and health?
No, in the networks you have to decide what you want and who is going to. Usually it goes around. It's a very equal system, yeah.
There's a rotation?
Rotation, yeah.
So we'll hear that in the Netherlands about in a minute, yeah?
But about the public health and primary health care, they have been together and managed together for a long time. So services like health checks, vaccinations, and lifestyle advice, they are in the social and health centers. But there is also cooperation with these new well-being services, counties, and municipalities. And they have a negotiation and they make an agreement about this promoting health and well-being. So
you have a promotion of health and well-being plan for all of them?
All?
A shared plan?
Yeah.
Shared targets, objectives?
We have 22 well-being areas. So we have 22 quite different, but they all have the same issues inside. Yeah.
Beautiful.
But there is also these NGOs and the private operators who supplement these public health and social services.
Well, your dream, Vesna, and your achievement. So NGOs, how do you integrate NGOs into this network?
They get funded.
They get
from the well-being.
Pilar, back to money. They get funding to support that, the NGOs.
Yeah.
Excellent. One other question very quickly. Finland, again, has been doing that for years, and there are other countries as well, where social and primary health care work together, have a shared budget, have shared centers, and it's never easy to differentiate what is the need of a patient. Is it health, is social care? There's a continuity here. How does that work in Finland? It's been there forever. You've been sharing budgets. Isn't there a fight and competition for the money?
No, but now because we have this reform. But I have to say that the slide, I think Deepak or was it Melita, showing that the private healthcare has the resources like this, the flat curve, and the specialized healthcare like this. That same thing in Finland. Yeah.
So Finland is working well, but still we see an increase in a specialized care and not in primary health care.
Yeah.
Why is that, Tina? If it's working so well...
But now we have an opportunity because now the budget comes from the state to the well-being services counties, and they have the county councils that they divide. And now all the money comes from one point and they have to deal it. So hopefully we now have more funding for the primary health care, since before the reform there was more than 130 organizers of primary health care.
Because primary health care in Finland
22.
was organized in municipalities, right?
It used to be, yeah.
So you moved from the municipality to the county.
Yeah.
Because why?
Because we were lack of workforce and money, and we have very rapidly aging population.
But the municipalities are still integrated with these counties.
Yeah, they have these agreements with the public health and or the promotion of health and well-being. Yeah.
Thanks very much. We'll move in a minute, and I'll go back to all of you on the skill mix area. But before we go that, I think we have Slido.
Yeah, we have more
Pilar?
questions. Yes, please, if we can put in the screen, on the screen. Okay, now we are going to talk about the integration roles and effectiveness in contingent to the introduction of broader mix of health professionals. That is a very, very key element, skills and teams. Then we are going to start the answers. Overcoming the traditional medical hierarchy and culture, poor communication and working relationship between primary healthcare professionals. You can start to answer, please. Inappropriate laws and professional regulations, or inappropriate organizational frameworks not conducive to include and work together with allied health professionals. Poor incentives. I don't know if it's working the model because there is no moving. Ah, okay,
Yes.
great. Okay, the poor incentive, oh my God, so 100%. Well, insufficient and inappropriate training and education. Allied health professionals in primary health care are unavoidable and the only solution to family doctor shortage, or not relevant in my country. Then let's see, Josep, as you see, the poor incentive is, well, no, more or less now is equivalent with the organization framework. That is something so important. Things are changing very fast. I don't know. Maybe Joseph, you can just
again,
take...
it's about money, including financial, Pilar. It's about incentives for all the various professions to work together.
Well,
again, it's funny today. We get a lot money and organizational schemes, isn't it?
Yeah.
Vesna doesn't agree. She's never agreed with me all her life. But we'll talk about that in a minute. But that's the voting of the people, Vesna. The people are telling us that is organizational frameworks to work together, incentives to work together. Evout is assenting. We'll talk about that in a minute, Evout. Overcoming the traditional medical hierarchy culture, I don't think is that much in our country, Pilar, this one. Sorry, there are many answers. Actually, there's a repetition between laws and professional regulations. We put it twice. But clearly, we get a very good sense as to what people think are the most important elements. So we move now to Rebecca Bex-Fisher here to tell us about the UK. I said earlier that Finland, and indeed Slovenia and Spain, and the UK as well. UK has traditionally had a very prestigious general practice. And you are a general practitioner, as you are, Tina. Sorry, I introduced you earlier. Tina is working for the National Institute of Public Health in Finland and in charge of assessing all these new reforms and doing research in primary health care. Your counterpart in the Health Foundation, the largest foundation in Europe, is in the UK. Bex is working as a GP as well, of the new generation of GPs, and someone who's been studying some extent, the successes and some of the declines of general practice. General practice has been traditionally a university department They make good money, the general practitioners. And now, in recent years, we've been put a lot of emphasis to bring these new professions, these allied health professionals. How does that go? How do you do that? How do you implement that? Are you very hierarchical in the UK as well, between GPs and the rest?
Look, inevitably, Joseph, I think we're too hierarchical. I wish we were less hierarchical. I'm just going to zoom out for a bit of context as to what we've done. And actually, I'm going to be clear that this isn't a whole UK thing. As many of you will know, health is devolved across the 4 nations of the UK. So the examples I'm going to draw on are from England alone. But that helps you contextualize some of the numbers. So we have got over the problem of incentives. From 2019, the government invested £1.8 billion, so well over 2 billion euros, in trying to introduce. Initially, the target was 26,000 allied health professionals across general practice in England. So that is a pretty massive investment. For context, we have just over 6,000, about 6,300 GP practices. So we're talking about 5 or 6 on average extra allied health professionals in each practice. But to complicate things, we didn't do it on a practice-by-practice basis. We also introduced something called primary care networks. So there was this requirement for practices to work together to share these staff. So we have not only new and a different skill set of staff, but we have these staff working across groups of practices, so larger populations, 30 to 50,000, rather than perhaps 5 to 10,000 patients than we had before. The reason I want to explain all that is because it gives you some context for the scale of the transformation that we have in England at the moment in our workforce in primary care. Some things have gone very well. Recruitment has gone brilliantly. So the initial government target was 26,000 additional health professionals. This covers a range from, initially it was a relatively small list, physios, paramedics, social prescribing link workers. That was a new role for us in the NHS.
Can I ask you about social prescribing? Because I think it's one of the very exciting areas. I know Finland, I know many other countries are doing it, and Spain. Can you tell us a bit more on social prescribing, please?
Yeah, so the intention, it was initially a fairly broad concept. This role, we have worked on what the job description for this role should be, but the intention was that social prescribing link workers would sit within general practice surgeries in these primary care networks, and they would act as a bridge between general practice and the community, and voluntary and community sector organisations within the community. So let's say a patient comes to see me, and one of the things that we identify within the conversation is that perhaps they are struggling with loneliness and social isolation, perhaps they're also struggling with some debt, and maybe their boiler has broken down and their house is cold. I can speak to the social prescribing link worker in our practice, connect the patient with them, and the social prescribing link worker will then be able to connect them with organisations within the community who can support them. That's the theory, at least. The challenge is, or one of the challenges, is that relies, as you will all have realised, on there being community assets and infrastructure at the other end of this pipeline to actually be able to help the patient with the problems they're experiencing.
Can you continue, because I interrupted you on that. I mean, you were talking about the profile of these skill mix in general practice. How are they integrating now? You said the scale of the change is enormous. So at least you got the funds that Spain is looking for, the funds that all the countries, apparently you got the money. So what else you need, Rebecca?
So it turns out that what you need is an awful lot of transformation support, and that's kind of what we didn't do. So we gave the money, and that has been successful. We've recruited 34,000 allied health professionals since 2019. So when you ring-fence funding, that funding has been utilised, and it's been utilised. It was protected for that purpose. So that, I think, has worked very well. But I think what we probably failed to acknowledge was the scale of this transformation. And a thing that I think perhaps wasn't on that slide is actually, well, what is the management capacity and support that you need within primary care to support huge transformation programs like this? What it has led to for us is that we have some very practical challenge. For example, where are we going to put these people? We have, in some cases, very modern, amazing primary care estates, but in other cases, somewhat elderly clinics, and we just don't have enough space for all of these extra staff that we have. And of course, space matters, because it's, you know, how easy is it for us to talk to each other as professionals matters. But also, we have perhaps not had enough clarity over what is the purpose of some of these roles, what is the regulatory framework, How do we supervise them? And you can come and study and learn from all of our mistakes, because we're moving forward with this and we are now sort of retrofitting some policies.
And that's what we heard, Rebecca. That's what we heard. Organizational models, aligning, and so on, and incentives. Are they merging? Are you saying it's not about physical space, as you say, but what is the organizational model in which all these very different professionals, these hierarchies, end up working together? The Finns have resolved it, apparently. How do you resolve it, the British? How do you get them working together? What incentives you give so they're equal professionals, equally empowered?
I don't know the answer to that, Josep, because I think we haven't done it well enough in England at the moment. I think what we have allowed is the classic phrase, 1,000 flowers to bloom. And I think some of you will recognize this, is that in primary care as a whole, we often value our autonomy and we value our localism, and we say, well, you know, let me decide what is right for my practice and my population, and I will implement this skills mix change in the way that makes sense to me. And I think what that has led to, and this is slightly anecdotal because remember, this is very recent, so we're still trying to work out what the outcomes from this are, and we don't yet know. My suspicion is that what this has led to is a lot of heterogeneity. In some areas, these staff are working really well, and I think so much of this is about culture. It's about the culture within organizations, and I think in some areas they have cultures that support good implementation, help people feel valued. They can put in supervision systems, they make people feel safe, all of the things we know we need. And in others, they don't.
One short question, short answer. Primary healthcare in the driving seat. The observatory hundreds of years ago did this volume about putting back primary healthcare in the driving seat, and we still struggle to put primary healthcare in the driving seat. You were saying in a prior conversation that actually you got money, but not as much money as the others. And in comparative terms, primary healthcare, like Finland, is losing. Why is that? We're not making a good case. I mean, you guys are making a powerful case for primary healthcare. Why are you not getting the money? And I'll go back to you and you, both of you, Sasha and Ewout, on that.
Look, I think it's enormously challenging. So I was actually quite looking at the slides earlier with some envy, because at the moment we have 8.4% of system spend in the NHS goes on primary care. So that's our lowest spend for 8 years. That's despite a host of government's commitments to move care into the community. And of course, as we all know, primary care, you know, we operate a tight gatekeeper system in the NHS. It delivers the vast, vast majority of patient contact. It's not enough money. I think, look, there are two answers to this for me. One is a values-led answer. One is about, and I was quite inspired listening to that first presentation, about what is the value of primary care around social justice, around equity? What is the role that we play in our communities? And that's a value-led argument. There are economic arguments about the productivity gains that we can create for our communities by making sure that their health and well-being is better looked after. But I think that for too long we have suffered from, you know, our health systems, power and money go hand in hand. We lack money, we lack power with health systems, and that is partly about the representation problem, and I think that's come up before, but is how we as primary care have more of a voice within power, within government. I think that for us is lacking at the moment.
Perfect. I'm going to park for a second the money issue, but I'm going back to it, promise, for our colleagues. And I want to go back, starting with you, Pilar or Pedro, a bit the skill mix and Vesna that we heard from Finland, the UK. How you resolve these new professionals in primary healthcare? How are you merging in Spain these different cultures? Culture, incentives, hierarchies, regulations.
So it's not easy to answer, because you have previous hierarchies between medical doctors, nurses, social care persons working in primary healthcare units. So
there's no hierarchy in Spain.
No, yes, there are hierarchies. Yeah, there are previous hierarchies. So when they start to work together, they grew up, and then it's not easy to find a way to get solutions to them. I think we need to have time to get everything settled, and also to train all professionals in how to work together and to just at least eliminate all the barriers between disciplines. But that's something that is hard to do.
Pilar, well, I know it's one of your hobby horses.
No, I mean, I think in this case, this is the importance of the role of the administration, because I think for us was very important the introduction of the nurses, the specialists in community health, but for other sectors, for instance, administrative sector, that is so important, is the administration role to increase their skill, to increase the role they can have as much as the other professionals that must be involved. And I think this is the main challenge for us. Of course, there are other professionals that are very, very important in the primary care, like the social workers as the physiotherapists and others, and the psychologists and other sectors. But this is the role of administration, and we have a big challenge and a big, I mean, we can improve a lot in this way, and this is one of our tasks. When we talk about shortness of resources, it's not only the number of people working, it's also to take advantage of all the quality of the resources, to take the best of each one.
It's a thing about being just with people that they work together and they go for the same goal.
And one of the important schemes that Deepa raised is if we can train them together. When they're babies, when they're small, first year of health of education, being nursing or doctors like the French do, we train them together as equals. That's one of the key elements. Vesna, you want to say something on the skill mix? I know that's an area close to your heart as well in Slovenia.
Well, we actually did it differently than UK. We also invested money, but all the money was invested in transformation. So what we did, it was first project-based. We developed the projects and we piloted it only in several, not in all, but in some of the primary health care centers, and there was a tender, so they had to apply and to be highly motivated that they will do the job. And then we piloted it with all these new profiles, and we invested a lot in training of the new profiles as well. When we had data, you know, that this really works, it was much easier then to systemize this. And trainings thereof, you know, were provided by Public Health Institute, and it was financed by Health Insurance Fund, partially, and partially through another international resource and by the ministry. So a lot.
But the merging went well. The merging of cultures of these different professionals.
Well, not everywhere. It was very important what the management of primary health center thought, you know, if they were for it, and that is why we did the standards, you know, to have really motivated centers. But now, when it's for all centers have multidisciplinary teams, and these health promotion centers is a little bit more difficult to make doctors really understand the advantage of having this in their facility and, you know, sending their patients there. But what we have realized, and I think this is really important, money is not enough. You know, having these pilots, introducing new profiles is not enough. What primary healthcare in Slovenia was loudly saying to the government, we want to have a development center, primary healthcare development center. We want to own this. It's not for public health to own it. Us, primary healthcare people, want to own the development that is, you know, ours, you know. So we are now looking at developing such a center. I know that in the audience we have Belgium and somebody who actually created such a center in Belgium, and this is what we are after. So the primary healthcare has a voice, you know, and they are the one in charge. They own the development. That is
Soraya Dalil here with us, the head of our global PhD program. That must sound music to your ears. That is PhD that owns it and leads it, the PhD perspective of the health system.
Jan is
Thank you,
sitting
Vesna.
there.
I'll bring you later, Jan, in the discussion. Ewout, you've been, and Sasha, I apologize, patiently waiting here. Ewout is one of my most senior people I have in the observatory, running many of our operations in the European Observatory, but you're a Dutchman. I mean, a Dutchman says a lot. So you know, you've been doing a lot of research on leadership, on thinking about health workforce, integrated care, among many other areas, as well as you know the Netherlands very well, another country that in the European rankings does pretty well in this field. So I'd like to hear, briefly, you've done some studies, some research recently about what are the key factors on integrating care. key factors on integrating all these professionals. Why is it so difficult to integrate care? It's a no-brainer. No one wants disintegrated care. It's a misnomer. Why we say we aim to integrated care? Why is integrated care doesn't happen with PHC? What are the key elements about? And how much we can learn from the Netherlands on the good and the bad there? Not easy.
So that is a gigantic question, and I think that the audience already started answering it, because in the Slido you saw that you said that the frameworks are the ones that are hindering us. And from this research across various projects that were successful, all of them said, and mostly integrated care networks based in primary care, focused on multimorbidity. I think that is also what we should discuss today, multimorbidity. That is another thing. They all said that they felt that often the national policies and the frameworks in place were the ones hindering them, and they spent lots of time, the successful projects, circumventing that. And so if we manage to come up with a better, I think, national frameworks in a conducive environment, and also to, with some good frameworks for the meso-level innovators to integrate better, I think that would go a long way already.
What are the other factors? Is it digital? These days we all talk about digital. What are the other factors that ensure this integration, Ivan?
I think digital is a huge enabler, but I would not start with digital. We had a whole, in Gastein, you remember, we had a whole session about digital with people who run a project implementing digital solutions in various countries. Very interesting. And in the end I said, so, what is then the most important factor? And he said, the people. The fact that they use it, that they are, also co-developers of those products, because they're the end user. That's very important, that you include all of these, all of the people who eventually be working with it. So it is an important one, but it's not, here is your innovation, and that they then fix everything. That will not work.
With your Dutch hat, you are one of the countries with the highest percentage of expenditure in integrated care, so much so that there are been introduced market mechanisms, all sorts of reforms there.
Yeah.
And the Dutch are very pleased about integrated care, less so now because there's less cash. What's happening there?
So it's interesting, because I know everybody thinks the Dutch are spending a lot on healthcare, total healthcare, that's true. But if you would take out long-term care spending, which is in the Netherlands the largest category of spending, before outpatient care, that's a broader basket including primary health care, and then hospital care. So if you take that out, and you could see that on some of the slides earlier, I think the ones that Melita showed, you will see that the Netherlands is perhaps not spending that much in purchasing power parity per capita. So it's not that dramatic as the Dutch often think it is. It's just that it's always on the national psyche, something that you don't, for example, see in Germany, where this is no debate at all.
Mental health is one of the challenges we have across, and we talked with all of you about integrating mental health in primary healthcare. Is something you want to comment on that? Because it's a very important area, as we were saying earlier, as you say, multimorbidity about.
Yeah, and I think mental health has been recognized in the Netherlands already years ago, also in primary care, as a key issue to address. So I think 80% of all practices have a mental health nurse nowadays.
A mental health nurse in 80% of the practices.
I think yeah.
Is that something I see in other countries?
So
sure, in Finland, UK? Not quite.
We're on our way. We in theory have them through these primary care networks. In practice, we have got complicated contractual arrangements which hold things up.
Complicated contracting arrangements. I'd like to debate that later. Vesna, Spain.
We have
mental health.
Yeah, we are just now introducing everywhere mental health centers in addition to health promotion centers with, professionals.
Inside primary health care.
Inside primary health care.
Spain, Pilar, or Pedro.
I think we need to be careful when we talk about this. So one thing is that in primary healthcare we can introduce a mental health agenda, and the other one is saying that we can provide solutions to the mental health problem by having more professionals in primary healthcare, which is not the case. So what we are doing right now is at least trying to address social determinants of mental health while trying to introduce more medical doctors and more specialists in primary healthcare regarding mental health. But I think the main focus should be on the mental health crisis, which is outside the medical sector. We should be careful with that.
And the other question is to strengthen the mental health resources for severe diseases, severe mental diseases, but leave this mental health structure for severe mental health diseases. And then, as Pedro said, that's the other things related to the mental health disorders, that just some problems related to the difficulties of life, difficulties of social determinants.
Thank you. Let's talk about money. Money.
Money, yeah.
How much are countries spending? How do we get them to spend more on that? This has been our worry today throughout, and we haven't heard we heard some solutions, but what would be your reflections on that?
So I think that some of the figures were shown. It's a little bit difficult exactly to say how much countries are spending also in really good comparative terms. I think we focus a lot also on the percentages. Of course, that gives a good idea of how spending and allocation is prioritized, but we should not forget that in the end it still matters how much you spend in absolute terms. So even though a country is spending less as a percentage, can still be one of the higher spenders in Europe. So that is one thing. Now I think this is really about building the case, and we've been, of course, producing policy briefs about that I should recommend all of you to download and read. And, you know, they have some common elements where you're advocating for. Of course, you first need to have a proper analysis of, you know, where is there a problem? Isn't there enough money? Like, is it the benefit package for primary care? Don't we have good facilities? And then you choose where you invest. But you will want to show that there are other benefits of this spending as well as for, to be honest, other parts of the health system as well. Co-benefits that go beyond the health system, I think, is something very powerful. I think you also need to realize that and make people, the public understand that that some of these investments take time before they take hold. So you should also have a long-term perspective on this. So that it makes the system more sustainable going forward in the future. So sometimes these results will materialize after many years. And in the end, spending on health is very popular. I think the public is in favor. So politically, it won't hurt. Of course, you need to find the money and convince the Minister of Finance. That's another discussion.
I'd like to talk about discussion with the Minister of Finance. We've been doing a lot of work on that as well. Bex.
Just to come in briefly, so I agree with you on the public. The public in the UK are very much in favour of spending more money on health and care. But I think there are three things. One is total spend. We've talked a bit about that. The second that we've talked about less is distribution of spend within primary care. So in England at the moment, we still have what we call an inverse care law, which means that practices in poorer areas, despite having more health need, actually get less money, and they have fewer GPs. They also have fewer of that allied health professional workforce than practices in more affluent areas. So we have a maldistribution of funding. So total spend, distribution of spend. And then I think the third thing that Ewout just touched on is how you can link that spend to outcomes. And I think that's where the point I was making earlier, you know, partly there is a values-based answer for the why more money in primary care. But I think my question for all of us, and I would love to talk to you about your solutions to this as well, is there is a value for money proposition here that governments in constrained financial times are juggling with. And we have to understand that that is the reality, is what outcomes do we guarantee for money? And it is not as easy in primary care. We can't just be like, you pay me this much money for a hip replacement or a knee replacement. Our outcomes are harder to tie to finances, and I think that's a very real challenge for all of us.
That's beautiful. How we show outcomes in an area that the outcomes are very broader, not like clearly what you get out of a hip replacement. Pilar.
I'm very glad to introduce you, Sasha Jenko, and especially just to ask her to explain a little. She's the head of health sector in DG Reform in the European Commission. And as everyday life, in our lives, the European Commission is much more important, especially on health. We are building the Europe of health. And then for that, DG Reform has a very important role to support countries in these reforms. We were very happy to share a very important study related to the reforms in primary care health too. Then, Sasa, can you explain how you work in DG reform and how you support the health sector, especially in primary care, in our country and other countries?
Thank you very much, Pilar. Señoras y señores, muchas gracias por la invitación. So in DG Reform, we are part of the Commission services, but we are a little bit of a different animal. So what we do is we listen to the member states when they have a need and they come to us, and then we, together with the member states, design a reform, and then we help them to implement reform and monitor the reform. We work together with the other services within the Commission, so with DG Sante and with others, to somehow tie the knots and to bring the policy, the European policies, also to the national level. So in primary care, we are aware that it is, first of all, now not the gatekeeper, but the heart of the health system. I will remember that forever. And we have really tried to somehow bring that and illustrate that at the European level as well. So one of the first case examples was together with Professor de Meissner in Flanders, where we supported them to establish this primary care center and start the reform. Then we supported Austria with the setup of the primary healthcare units. Similarly, in Slovakia as well, we are supporting Estonia as well with the primary healthcare reform. Lately, we are helping them to integrate mental health services as well. Also, we are working closely with Slovenia and with Vesna on the primary care reform, basically on the triage center for non-emergent services. Also, as a spillover effect, and talking about money and building the case, we have supported Austria in the negotiations with the Ministries of Finance to basically build the case and to allocate even more funds in these difficult times to the primary care. But as we have heard from many of you, it's not about the money only. So it is really important to secure the funds because starting a change is very difficult. You need to align all the stakeholders, the political commitment with the resources. But then you need to have these champions of reforms, the visionary leaders, and then excellent teams on the ground that understand the context, that understand the culture, that speak the language, that actually implement that on the ground. So I think that what I have learned as well is we have to go beyond what the WHO colleagues have said, the biomedical approach, to integrate also the mental health as we are doing now, to integrate the socioeconomic status, so talking about vulnerable populations, and really say that this la salud empieza en la comunidad, no en la clínica. I think this is really important for everyone. What I would like to stress as well is that what I have heard today from Spain, I think that the Spanish colleagues should be really proud of what they are achieving. There are so many member states that are in similar position, so you are not alone and you have achieved so much already, and we would be really happy to somehow catalyze this good practice and best practice to the other regions of the European Union and to the other member states. Thank you.
Thank you, Sasa. I think we learn a lot about the best practices from other European countries that you share with us. And I would like also to talk a little more about our experience. I think we are very grateful to you because we understand the peculiarities of our system, and you talk not only with the Ministry of Health, but also with the regions, also with the civil societies, scientific societies, and the patient associations. And then with this experience, can you explain a little more how you get this experience? If this experience is also, we can export this Spanish model to other European countries?
So again, here I think it is really important. I mean, all the countries and regions know what they have to do. So sometimes they just need a catalyzer. And I mean, our service comes more as a support service to sort of listen and to bring all the stakeholders around the table. And I think this is really important. And it's sometimes just taking the time also to listen to each other. First of all, to listen to all the healthcare professionals, because here we are focusing on primary care, which is the heart. But it is very important to take into account also the other types of care. And if we are strengthening one pillar, then the other has to let go. So we had to catalyze and are still doing very complex dialogues between different disciplines, between the health professionals, and how to redistribute the competencies. I mean, there is no one recipe, but what works every time is to listen, to somehow catalyze the dialogue, to somehow catalyze also the exchange between different regions, because in Spain you have so many regions, and each of the region has a sort of its strength in one particular case. So there is such richness already within the country where you can learn from each other. And then also, I mean, what we have seen, for example, bring those best practices elsewhere. We are working with Andalusia now on with mental health care for vulnerable children. So we are trying to integrate that into the primary care. Then we are working with the Basque Country on the integrated care, so primary care and integration of public health. We are working with Catalonia on digital skills and how to set up sort of the DigiComp. So there are so many things, and those are all avant-garde countries. So there are other countries that are always already learning from you.
Thank you so much, Sasa. Maybe we are at the time, no? Now we have.
Yes, perhaps we can have some we can perhaps, with your permission, go a tiny bit more over the time as we start later, perhaps another 15 minutes, to hear some questions from the room, Pilar,
yeah,
and from online. But
Perfect.
Allow me to mention one point, highlight one point, supporting transformation as in making the case from health to the Ministry of Finance. Some work that the Observatory has been collaborating with you, making a powerful case to get more money. I think that it's on your credit that is also supporting the process of change, the transformation, the political economy that we heard from Melita, that we heard from Deepa today, and our colleagues. Pilar, shall we start with online, perhaps?
Yes, please.
What do we have on online? Please, give us a sense of what people are saying. And maybe, Deepa, you're going to do that. Give us a sense. What is the sense out there?
So there's lots of questions.
We don't hear you. Go.
Can you hear me now? Okay. So we have a grouping of questions around the community perspectives. We have a grouping of questions, especially around this piece, this integration piece, whether it be with social care or public health. And I'll start with the question around the community and about this community perspective. And one question that came was, what the panel thinks is the most important barrier to really implement it. And other participants had suggested 2 potential barriers, and they wanted to know what you think about that as panelists. And one was that interdisciplinarity might be one of the key challenges or barriers to implementing that community perspective. And the other one is the fact that sort of the modern world is starting to create consumers of services rather than patients and active citizens. And is that a key challenge, a barrier to having a more community-oriented primary health care?
Are any other issues you heard from the online that are people echoing the messages we get?
Yes, people are definitely echoing the messages that we hear, especially around integration, around those challenges, around financing. There's also a lot of questions around the practicalities of bringing together multidisciplinary teams and getting family physicians to work across different professions, and mechanisms that can be used to really relieve the family physician to have more time for what he or she does best. And so more practical questions on that front. So we can maybe put through 2 or 3 other questions later if we have time, and maybe
Perfect,
start
thank
with the
you.
community one.
Thank you very much. For the panelists, I'll give you 1 minute each at the end to consider what you heard now and what you consider what the online participants. Then at the end, Pilar, you will conclude us as the key organizer with the lessons, followed by the other key organizer, and which is the WHO Center for Primary Healthcare, Melita Jakob. So let's take some views from the floor. We'll not go over more than 15 minutes over the time, promise. And then I'll ask you to please conclude whatever aspects you want to pick up, yeah? Who's taking a microphone to the floor, please? Contributions, not complicated questions, just contributions, please. Can more microphones go around running, please?
Yeah, thank you. Thank you so much. Thank you for the panel. That was really interesting. I'm Sara Calderon. I'm an academic GP, Spanish, but currently working in the UK. And my comment was around the additional professional skills, and I wanted to ask, the fact that there's some evidence already suggesting that these additional roles can sometimes lead to some fragmentation in primary care, and also increased workload for GPs. So that's kind of problematic, right? Because it's meant to solve the increased workload. So my question was around, why does this happen, and what can we do about this? If I may, I feel that one explanation can be related to the fact that dealing with undifferentiated problems in primary care requires generalist skill sets, and we're unsure about whether this kind of additional roles can really deliver this. And the other one has to do with what kind of Dr. Bex-Fisher said around how we're implementing this really, and the fact that we're sometimes compromising maybe relationship continuity of care. So yeah, I'd like
Bex,
to hear.
you may want to pick up that one, as well as perhaps some of the others. Continuity, integration, fragmentation seems to be obviously a challenge. Please, Jan, thank you for being here again.
Thank you for the opportunity to contribute. What I see is that many countries face the problem when they go from a hospital-based system to a primary healthcare-based system, that you have to pay the transition costs. And then you have to pay twice, because your hospital has to be in function, whilst you have to invest in the new premises, primary care-based, community-based, and so on. And I think that's a bottleneck for many countries, also for politicians to sell that kind of transition to their voters finally. I was wondering if
how we sell that, Jan, because politicians have a low life expectancy. So how do we sell it to them to wait for that transition?
Well, I think that...
Give us the answer, not the question.
What?
Give us the answer, not the question.
I think the politicians have a very difficult task nowadays. And we have to try to help them as much as possible to understand, for instance, why investing in primary health care is probably not only good for the health of their population, but probably also good for the political sustainability of the democracy, what's the basis of our society. I think that investing in primary health care is investing in a sustainable democratic society.
I think that's exactly what we need to do, Pilar. Pedro, colleagues, I'd like you to reflect on that. In a moment of populism and challenge, we can demonstrate that primary health care is good for sustainability, for security, for democracy. But I'll get you back on that in a minute. More questions from the floor.
My question was not yet there. My question is if international organizations like EU, World Bank and so on could not help countries that have a clear plan to pay for the transition costs, because that would make it much more easy to go from the one to the other situation.
I'd like to hear from you, Sasha, on paying for that, and maybe Melita, when you conclude how the WHO is supporting that. Brilliant point. Thank you very much. More points, please. Quick.
Hello.
More points.
Yeah, I think it's my turn. Thank you very much for your so interesting comments. And I'd just like to share 2 reflections. Well, I come from Seville in Spain. First of all, I consider that public health is very, very integrated into primary care, because for us, prevention of diseases, promotion of health, it's part of primary care. Also, we have seen even the management of outbreaks, how we deal with them. And the second one is for mental health. We really need to implement mental health in primary care. Why? Because we work where people live, and the accessibility is very important for them, taking into account the stigma of mental health. So this is something we need to improve in our systems, because it's not enough one mental health nurse in a district, in a primary care district, that also depends on the mental health service that is located in the hospital. So we need to integrate those professionals, those categories in the primary care team.
Sounds
Thanks.
music to our ears and our presenters. They've been talking a lot about that, right? More points, please. En Spanish, en español, si quieren ustedes. Tenemos traducción simultánea. All right. Anything else from the web, Deepa? Where are you, Deepa? Anything else you want to add?
Hi.
Okay.
Yes, we have more. Actually, we have so many questions that we are not going to be able to address them all. But just two more. One is about time, because we have been talking a lot about fascination with technology, but then we know that actually in primary care, time is the most precious technology that we have, right? And the question is, in context in which there is difficult to recruit more family physicians, what mechanisms can be used to increase the consultation time that is devoted to each patient? This is one. And the other one is a little bit more high level. We have been working about building and making the case for primary healthcare. So what is the role of other sectors in making this happen and in supporting primary healthcare transformations?
I like that very much. If you can bring that one in your comments, please. I think we are about set. So let's have 1 minute each, starting with Pedro. And then we'll do the wrap-up by Pilar and Melita.
Okay, thanks so much for all the comments. I think that just to finish, I will go back to my original presentation, talking about what can we do to tackle social determinants of health from a primary healthcare perspective. I think there are three things that we can do and that we can support from the Ministry of Health. First of one is dialogue and try to integrate systems. That's the most simple one, but that's the first one. The second one is to facilitate the life to public health, to primary healthcare professionals. And I think that's the most important one. We need to end bureaucracy. We need to reorganize the task in primary healthcare centers. That will give us time and will give time to primary healthcare workers to do more community health. And the third thing, and it's the most difficult one because it's the one that we are not responsible for that, is to take into account not only the social determinants of health, but the social determinants of health of community participation. If people don't have time, they cannot participate in public matters. So we have to work with other ministries, not just to improve health, but also to improve democracy, to improve participation in daily life. And I think we can be leaders on that, but we need other ministries. And I think that's all my 3 points.
Absolutely perfect. Vesna, community, you've been talking about community and determinants a lot as well. But and a key question that came from the web participants.
Well, I'm going to focus on something else because I was challenged by Jan. He said, you know, that maybe politicians don't really understand, but our neighbor is Austria. I think political level, the ministry really understands that they have to invest in primary health care, but there is a resistance among doctors there. So we have to maybe think of why this
Doctors don't want to invest in primary health care?
Well, young doctors do. I'm not to speak for Austria, but I'm sorry that we don't have Austria here. But younger Austrian doctors do. They want to work together and to have other stuff, so on, you know, but there was tradition of solo practices there and these kind of things. I mean, I just want to say it's not always the government that doesn't understand, because it was very much invested by WHO, you know, recently, in a recent decade, actually, to promote primary health care, and I think people do understand that this is where we should invest, but they don't know how. And I would also remind us all that everything is a process. You cannot do it from today to tomorrow. You really need to invest. Talking of time, I want to say, you know, when we give additional roles to primary healthcare teams, because it's not just the doctors, you know. We have to also think about less administrative burden that they are confronted with. I heard somebody from Spain saying there's so much administrative. Yes, it is. So let's use the digitalization for less burden, not for more. This is what is happening now. And also let's define the roles, you know, who is who, and give them the chance, you know, to enjoy what they are doing. And that is why I was bringing in this Center for the Development of Primary Health Care, because they should be able to monitor the successes and somebody be there for them, you know, and work with physicians, nurses, and everyone, modeling some new things and so on. Otherwise, you know, just somebody telling you what to do, you don't feel really own it. Why would you do it then, you know? So this is what I think is important to think, and trainings, of course. There should be trainings. You are speaking of different people in the team and so on. You have to provide training. And we are speaking very often, you know, that this training should be provided for the whole team, not separately.
As equals.
Because then they would understand better who does what, you know. It's actually team building then.
Perfect, thank you very much. Tina, any reflections on that? We heard one question just now about what other sectors can do for primary care, not what only primary care can do for the others. How does that? Actually, health in all policies, I have to say as well, it's a concept that came from Finland. In the prior presidency, actually observed it in the volume with you on health in all policies, and there you are. It's now a core element of our thinking. So what other sectors can do for primary health care?
Because we have merged everything. So, and in our legislation, social and health is promoted that they have to coordinate. And I think the key issue that all that is involved benefits. So the customer benefits because he is or she is guided to the right service he needs. And it shortens and streamlines the processes, and the customer is more satisfied. But it's more well-being for the professionals too, because they can see that the services are more qualified, the quality of services improves, and the whole system is more efficient. So it benefits everybody. But there was a lady talking about the mental health issues that they have to be, because in Finland we have the mental health nurses working also in the schools, because the anxiety and the mild depression, it's very huge after the COVID with the youngsters. And also we have specialists from the specialized healthcare who just come to the health centers to give their expertise, and we have the communication about the patient's problems. And it's an educational thing also in the same time. It's very worthwhile to think about that. And what I want to say is in Finland, the health centers or the social and health centers, we usually have 6 to 40 doctors there. So they are quite big, and it's very easy to have the other multi-professional teams there. And patients are directed straightly to the physiotherapist in some cases. Mm-hmm. They are straightly directed to the psychiatric nurses. So everything doesn't have to go through doctors. That's very important. And what I want to say about the digital thing, we have nowadays digital health centers and digital family centers, but what I have heard, when they have doctors or nurses to the digital health center, they have to have worked in the face-to-face, so they know the local conditions and everything. But what thing is important, because we have the aging population, and the workforce is getting smaller. But if a nurse is old and can't work in the physical appointment, she or he can work in the digital health center. They have a huge amount of knowledge. It's very worthwhile to have them in board still.
Digital health centers.
Yeah.
Bex, lots of space for allied health professionals. You have to have bigger buildings in the UK. Your reflections, please.
We do need bigger
and
buildings.
And the transition as well.
And therefore a little more money. But to move on from the only money point, look, I think we all in this room will instinctively understand what primary healthcare can bring. I think one of the challenges is that sometimes other people also think that primary healthcare can bring an awful lot too, and it becomes a kind of bucket that the wants of everything within the health system or the social determinants gets chucked into. And there's a really difficult tightrope for us to walk as folk in the primary health policy space, which is simultaneously saying, well, yes, we could do this and we see value to doing it, but actually, you know, what is our core purpose and how does our core purpose align with the available funding? And these are difficult questions, but I see from some nodding around the room that the UK is probably not the only one in grappling with this. And just to the question in the audience, for example, about continuity of care, I think that's a really excellent example. There is so much evidence for the benefit of relational continuity of care between caregiver and patient in primary care. There was an interesting paper last week that I think for the first time really tied relational continuity of care between individual practitioner and patient to productivity in primary care as well. Our workforce will change. Continuity of care is going to be something that we need to think incredibly carefully about. And so I think what I'm trying to get at is in this broad melee of, yes, there's a lot that primary care can do, but we actually have to sometimes come back to, well, what is its core purposes? How are we most effective? And how in these very difficult conversations are we going to protect what we know that we can deliver and argue for its value, relative, sure, to other things that do have value, but how do we retain what is core to us and make the case for that within a very, very complicated system for all of us at the moment?
Perfect. Arguing for its value. Ewout.
Okay, no, I was really glad that Vesna brought up training, what we call probably interprofessional curricula. I think that is needed also to build the new generation who understands the issues, who understands multimorbidity, understands integration, understands what the others are doing, the other professions. So a really important point. I had something on financing because it was brought up, and we talked about funding in general, but maybe not about payment mechanisms. And that is, of course, a big issue in the Netherlands. And the thing that I wanted to say about it is that, well, you can perhaps use it for integration, and the Dutch try with bundled payments, where you, for specific chronic diseases, you get one bundled payment if groups of providers, work together. That doesn't really work well, I think, for people with multimorbidity, and they need another approach. You need a holistic approach, not disease-based, and that also needs rethinking of some of these financing mechanisms, and that will be, not for all countries, but many countries, a real challenge in the future. So that's one point I wanted to make. And the last one was about those consultation times that we were talking about. This is also a big agenda point in the Netherlands where they would like to see more time. But the fact is that even though in the Netherlands we have many more GPs than only 10 years ago, work pressures are enormous. And it's really hard also, with growing practices, with all these different people that you have to employ, administrative burden, etc., to run a practice. So what we now see also is a new development where people join a practice as a salaried worker, and practices that are often owned by private equity, and you can, on the one hand, maybe it's good for them, so they don't have all the administrative burden and other things are arranged for them, but it also has some serious questions, I think, going forward, when perhaps the commercial interests are taking the overhand in this development, and we see this in more countries, and we have worked on it also with the observatory, and something we really need to monitor going forward.
Indeed, and thank you for an area we didn't cover, which is the link of payment incentives to the outcomes. Although this is our El Dorado, to link incentives with outcomes, it's far more complex, as the Netherlands is showing us, and particularly with multimorbidity. So we want to pursue El Dorado, but getting to El Dorado is rather complex. So still, the link with outcomes and money is one way to go. Talking about money, but more than money, I think, Sasha, like the WHO, the European Commission is providing serious technical support as well to these member states. And want to reflect a bit on that question of funding, the question of support.
Thank you very much, Joseph. I think that what is really important and key is dialogue and collaboration with all the institutions, with other organizations, because it is very complex, as we have heard, to build the case for primary care. And I think that if we do it together and if we help to implement it at the local level with the right teams, with the right skill mix of teams as well, and with the right understanding, I think that here we can serve member states the most. What I wanted to add maybe, and what is really important as well for us at least, we have seen that every time that we start with a transformation or change management or reform, it is really important to communicate well right from the start to different stakeholders. So to the professionals, to the politicians, but also to the citizens. So what we are doing now is we are engaging with the professional PR agencies and communication agencies right from the start to help us design those messages that are really important. So
That's
with
absolutely.
that, and maybe just to end with the proverb that I like in Spanish is that la salud está encima de la riqueza. So, and I think that money will not solve all the problems. Thank you.
Indeed, health and well-being is above wealth in many ways. And key lessons from you today. Do you want us to wrap us up with some lessons on the overall meeting, Pilar?
Well, I think we talk about the situation of primary care in the different countries, in the different contexts. We also talk about all the challenges we have, but fortunately we talk also a lot about key recommendations. And in that sense, of course, we all agree in have enough funding to get all the challenges we have, but also we stress the importance of participation. And I think this is very important because it's important the organization to improve our time, to improve the time of the health professionals, and then have the possibility to enjoy the profession of business health. We also talk about the organization of how to integrate all the different health profiles, and this is very important. It's a role of administration, regional, national administration. We also talk about the importance of organization to integrate social care with health sector. That is a very important example of Finland. And we also talk about how to organize our health centers with the community to get much more participation, as Pedro stated. And in this sense also, I think it was very important to the reflection about how to improve the health in all policies, as Finland and Tina said, trying, for instance, with an example about educational centers, how to improve also these policies in all the sectors to improve and to protect and to improve the health of our population, and to integrate also the community with a clear profile, as I think this was very important, as Becca stated, Rebecca said, about something that is very important for us is the continuity of care. That is a way to integrate the community in the public health sector in primary care. And I think that also was, to me, very important, as you stated, Josep, what you stated about the payment mechanism for the different profiles and how to increment the increase. And again, I give thanks to Sasa for the effort to get the best practices in the different countries to learn of all of them. Then I think we have a time for Melita to give the conclusion.
Thank you very much. I'll stand next to you if that's all right. First of all, I really want to thank the Ministry of Health of Spain for involving us, WHO, and the Observatory in this conversation. We often see from countries when there is trouble, they don't want to share, they want to turn inwards, solve those problems first, and only then open up with lessons learned to the world. And I think this conversation has such great value, hopefully for this room, for your national discourse, but beyond this, for all the countries in Europe. So it's been absolutely delightful to be part of this process. On my own reflections, I would like to start where Sasha ended, that we need to communicate. But to communicate well, first what we need to do is listen. And for us policymakers and health system organizers, it's critical to have our ear to the voice of practice. I have a feeling that we often over-intellectualize our conversations. We always, as a rule, visit practices wherever we go. And whenever I go and look at multidisciplinary primary healthcare practices, what I hear is that the different health professionals, they want to work together because they see how much more powerful the results are, especially for complex situations, for complex cases. They don't have big barriers of their background, of their training. They want to work together. They don't have enough resources and time. And I think this came out very powerfully in this panel. So what we need to give them is give them the ability to do what they want to do, what they're trained to do, and what they're anyway doing well. So I think we need to get out of their way. Sometimes I think we need to get out of their way. We need to give them the resources to do what they want to do. And yes, there is great benefits. I think Rebecca mentioned great benefits from clarifying roles, but not over-prescribing roles. Because it could be that in one primary healthcare team, they decide about relative roles and responsibilities differently than in another one. Think of a crowded urban area with a lot of young families versus a rural area, isolation, elderly population. The roles and responsibilities in that team will be by necessity different. And if we get out of their way and we let autonomy work, they will figure it out as long as they have the resources to do so. And I will just finish, Josep, I know you're kicking me off the stage here, but there is one hardcore instrument that I think we didn't talk enough about, and we have to, which is enhanced population health management, empowered by data, empowered by big data. Being able to understand the composition of the population at community level and practice level, being able to identify the 10% highest risk, not just biomedically, but also social complexity, that gives a leg up to primary healthcare practices to be proactive and to go ahead of the problems rather than be reactive. And this is a tool that can unite all professions, looking at data and identify who can do what to reduce the percentage of high complexity in that community. Thank you very much for being part of this panel and being with us. And let all of us commit that we are going to keep listening to the voice of practice as we make these very important decisions. Thank you.
Thank you. Thank you, Pilar. Thank you, Melita, for these very powerful final words to conclude. And if there was one thing, as always, Melita, you and I think alike, I wanted to bring the communication element. Listening and communicating much better. We have such a powerful case. We have such a powerful case. So thank you. Thank you to the panelists. You did a great work in spite of my lousy moderation. Great co-moderator and bringing the points together, the speakers. Those online, thank you very much for bearing with us. And those in the room, the good news for you is you're coming back. We're going to have this afternoon, not for the online, I'm sorry. You're coming back this afternoon. We're going to have a very open debate with a number of experiences in our country. We'll be in Spanish, where we have Javier Padilla, Secretary of State, and Tomás Zapata, my colleague from WHO, opening us and closing us together with Pedro Gullón, and we'll have Paloma Calleja and Tony Dedeu running the show and learning a lot from each other. So, due to my lousy moderation, not yours, we'll start at 2:40 than 2:30, so you have to eat slightly faster. Thank you very much for being here.
No, 3. We come back at 3. At 3.
At 3?
Yeah. We come back at 3.
Okay, so you have more time to eat and digest. Thank you very much for that. So at 3, we're all back. Thank you very much.
Volvemos a las 15 horas y luego la conexión de la tarde es otra URL que está colgada en la página web.